Am I audible? Hello, good morning.
Yes, ma'am, you are audible.
So, a very good morning to all of you. And today we are going to start the day 4 of the pediatric COVID management online training. And I will invite Dr. Nishant Verma, Additional Professor, Department of Pediatrics, to start the first lecture of the today's session, that is ARDS and its management. Dr. Nishant, are you there?
I think he is joining. I had a word with him, so he is joining.
Okay.
Maybe some network issues. So
Yeah,
he'll
yeah.
join.
Okay. The lecture will be started in a while. That is why no voice is coming. The presenter is just joining.
So we are so sorry for the delay. Dr. Nishant is just joining in a while. He is facing some network issues.
I'll start 5 minutes. Give me 5 minutes.
Dr. Nishant, are you able to do it?
Yes, just a second.
Okay, okay.
Actually, there was a problem in internet.
Okay, okay. No issues. Please do.
Are my slides?
Yes, yes. Visible, audible, both. Please start.
Okay, thank you. So good afternoon, everybody. I'm extremely sorry for this delay because of some problem in our internet. Today, I'll be talking about ARDS in COVID. ARDS in COVID, we will be focusing on severe COVID as well as ARDS, how to identify ARDS, and what is the ventilatory strategy and pharmacological therapy for severe COVID and ARDS. So the learning goals for the present seminar would be, present talk would be definition of pediatric ARDS and severe COVID pneumonia in children, lab evaluation of severe COVID, pharmacological treatment, the respiratory support which we have to provide for these children, indications for mechanical ventilation, and what ventilatory strategy we should follow if we are going to ventilate a kid with ARDS. So when we talk about the typical clinical course of a COVID-19 child, which is complicated by ARDS, so this diagram is a representation of what actually happens. On x-axis is the timeline, and on y-axis is the severity. So the typical incubation period is around 5 days, and at the onset of symptoms, the infectivity of a child or of an adult is maximum. So after 5 days of incubation period, the child becomes symptomatic, and at that time he is most infectious. This is followed by the viral load declines, but the clinical features persist. So initial 1 week is the early phase when a child typically will have fever, cough, body ache, and by the end of 1 week, there is development of dyspnea. However, majority of children will not develop dyspnea. They would improve only after this initial 1 week of malaise and upper respiratory tract infection. But a fraction would develop dyspnea, and then as the disease severity progresses, the inflammatory phase sets in. And this inflammatory or hyperinflammatory phase is responsible for damage to the alveoli and ARDS. A child who develops ARDS would typically need increased respiratory support in the form of BiPAP or an IV or invasive mechanical ventilation, and in extremely uncommon circumstances, even an ECMO may be needed. If ARDS is not identified and treated properly, if ARDS is not identified and treated properly, some children are going to die of this disease. How do we define severe COVID in children? So severe COVID is defined as pneumonia with any of the following clinical features: cyanosis, hypoxia, that is saturation of less than 90%, increased respiratory efforts, grunting, severe retractions, or letharginess, somnolence, or seizures. Some of these children will go on to develop a critical disease. So critical disease is a subset of severe disease where, in addition to these, a child would also have either ARDS or shock or multi-organ dysfunction syndrome. So this is the definition which has been given by the Indian Academy of Pediatrics and is the one which is most widely followed. Now, how common is severe COVID in children? So in a systematic review of around 7,500 pediatric patients with confirmed COVID-19, only 2% children with developed severe disease, which by severe disease we mean dyspnea, central cyanosis, or hypoxemia. Now, this is in contrast to adults, where around 5 to 10% go on to develop a severe disease. So in children, the prevalence and the chances of a child developing severe disease is less, and only 0.7% develop critical disease, which would mean develop ARDS, respiratory failure, or shock requiring ICU care. So on one hand, an adult with COVID, around 5% require ICU care, but in children, only around 0.7% require ICU care. So if translated, can become big numbers. That is why all this preparation is going on. When should we suspect ARDS in a child? So if a child is having progressive tachypnea, dyspnea, tachycardia, on auscultation of the chest, you are able to hear diffuse crackles, then you should suspect ARDS. If there is, in a child with respiratory distress, if there is onset of acute confusion, respiratory distress, cyanosis, diaphoresis, on X-ray you would see bilateral alveolar infiltrates, the oxygen saturation continues to decline and the oxygen requirement continues to rise. So these are the features of ARDS, onset of ARDS in a child. In adults, what we see is silent hypoxia. We also call it as happy hypoxia. Now this is uncommon in children. Children typically manifest symptoms. So they would appear sick when they develop ARDS. Adults may have silent hypoxia, but this is not common in children. Symptoms of cough, chest pain, wheezing, hemoptysis, and fever are inconsistent. So they may not be present in all children. So we cannot rely on presence of these symptoms for diagnosis of ARDS. How do we define pediatric ARDS? So this pediatric ARDS definition was given by the International Society of Critical Care Medicine, and this is the one which is most widely followed. For defining ARDS in children, we need certain parameters. So what are these parameters? One is a chest X-ray. So we need an X-ray for defining pediatric ARDS. We need certain oxygenation parameters from arterial blood gas, which include partial pressure of oxygen, which is PaO2, and SpO2. So SpO2 can be measured even without ABG from the pulse oximeter, but for PaO2, you need to have a ABG. So we also need to have certain parameters from the device which we are using, either a ventilator or a BiPAP machine. So these parameters include an FiO2 and mean airway pressure. So most of the machines now provide the mean airway or MAP values, but this can also be calculated by a very simple formula. From these parameters, we calculate certain values. These include a PF ratio, which is the ratio of PaO2 by FiO2, SF ratio, which is the ratio of SpO2 by FiO2, oxygenation index, which is product of FiO2 into MAP into 100 divided by PaO2, and oxygen saturation index, which is FiO2 into MAP into 100 divided by SpO2. For SF ratio and oxygen saturation index, we do not need a ABG. We can do it by the help of saturation, which can be measured from pulse oximeter. But for PF ratio and for oxygenation index, we need ABG as well. So once we have these values, the PARDS can be defined as when we have to exclude patients with perinatal related lung disease, which includes the BPD, bronchopulmonary dysplasia. The onset of disease should be within 7 days of a known clinical insult. We have to exclude cardiac and other fluid overload states as a cause for respiratory failure. And on the chest X-ray, there should be new infiltrates which are bilateral, consistent with acute lung parenchymal disease. We would see the X-ray findings in the next subsequent slides. And the oxygenation definition which we have to follow is need for NIV of full face mask or a BiPAP or a CPAP of more than 5 centimeters of water with a PF ratio of less than 300 or SF ratio of less than 264. If a child is on invasive mechanical ventilation, then ARDS can be categorized as mild, moderate, and severe based on the values of OI or OSI. So even if you don't have ABG, you can at least calculate the O oxygen saturation index. And based on the values, you can say if the value is between 5 to 7.5, it is mild, 7.5 to 12.3, it is moderate, and above 12.3 of OSI, it is severe pediatric ARDS. Now, for managing a child with ARDS, this categorization may not be very important, okay? Because management is a step ladder management. अगर बच्चे को first level पे management नहीं हो रहा, you are obviously going to escalate your treatment irrespective of what values you are getting from these. But once you have to document something, once you have to document improvement, then having these values are extremely useful, because if a child who had oxygenation index of 6, say 20 on day 1, on next day if it is 10, it would mean that the child is showing improvement. Next day if it falls less than 8, then he is out of ARDS. That is why for follow-up, having these values is important. There is another entity known as at risk of pediatric ARDS, and it is defined again by the Pediatric Critical Care Medicine Society. A child who is requiring nasal mask CPAP of BiPAP or BiPAP and is needing FiO2 of more than 40% to attain a saturation of 88 to 92, then this patient is at risk of pediatric ARDS. If a child is on simple oxygen face mask or a nasal cannula and his need for oxygen flow rates is higher than the age cutoff, so for less than 1 year, if the oxygen need is more than 2 liters, for 1 to 5 years, it is more than 4 liters. For 5 to 10, it is more than 6 liters. And for more than 10 years, if this need is more than 8 liters per minute, then such a child would be labeled as at risk of pediatric ARDS. He or she should be followed up very carefully, because these children may subsequently develop ARDS. Similarly, for a child with invasive mechanical ventilation, if he or she has an oxygen index of less than 4 or OSI of less than 5, but needs oxygen to maintain saturation of above 88%, he or she should be monitored carefully, because he is at risk of developing ARDS. Once we have diagnosed a child with ARDS, then how should we manage them? So how to manage severe COVID pneumonia and ARDS in children? So first is lab evaluation. So once we have a child with severe COVID pneumonia or ARDS, these are the investigations which you must do. One is complete blood count, which would include your hemoglobin, total count, differential count, platelet count, a baseline liver and kidney function test, inflammatory markers. So these are the bare minimum. You should have access to CRP levels, D-dimer levels, ferritin and procalcitonin, arterial blood gas, extremely important to identify PO2, PaO2, bicarbonate, and pH. So ABG must be there if you are going to manage a child with ARDS in your ICU, and access to a bedside chest X-ray. Now, these investigations may be repeated after 24 to 48 hours as per the child's clinical condition. In most of the scenarios, a child with ARDS in ICU, we would perform the inflammatory markers, including CBC, on a daily basis, an X-ray on a SOS basis, and ABG usually 12 hourly till the child's condition stabilizes. On chest X-ray, again you can grade the severity of ARDS on a chest X-ray. You can divide the chest X-ray PA view into 6 zones, 3 zones per lung: upper zone right left, mid zone right left, and lower zone right left. Sometimes instead of using 6 zones, you can also use 4 zones. The basic purpose again is to see the improvement. So once you repeat X-ray after say 24 to 48 hours, you want to see whether the score has increased or reduced. So having an objective measure helps you determine things in a better way. So the lung disease on X-ray can be graded as mild, moderate, and severe based on whether opacities are there in 1 to 2 zones, 3 to 4 zones, or more than 4 zones are involved on an X-ray. The typical findings on an X-ray are multifocal, bilateral peripheral opacities, opacities with rounded morphology, and predominantly the lower lung zones are affected. So this is a X-ray of a child with COVID-related ARDS who was admitted in our pediatric COVID ICU a few months back, and you can classically see almost all the lung zones are affected, barring one. So 1, 2, 3, 4, 5. The score would be on X-ray. 5 of 6 zones are affected. So this child had severe COVID pneumonia as per the radiological criteria. Another imaging modality which has gained popularity in the COVID era is HRCT. So HRCT of chest in evaluation of ARDS. Now, the role of HRCT in children is limited at best. You are not going to use it routinely. Because for doing a CT, the child must be hemodynamically stable. He should not be on high ventilatory settings because the risk of transport of a child who is on high ventilatory settings is extremely high. You cannot shift a child who is on HFNC or NIV for getting a CT done. So indications of doing CT are when there is high suspicion of COVID, but RT-PCR is negative. So then this is one scenario where you can consider doing a CT. And if there is unusual clinical cause, you are suspecting that the child has developed fungal pneumonia, because diagnosis of fungal pneumonia on an X-ray is difficult. CT are classical, can show you classical signs like crescent sign, the fungal balls, which can be seen on CT. So in such, if the child is not responding to your treatment, his or her radiological parameters on X-ray are worsening, then you may consider doing a CT, but it is not indicated routinely. And if CT is not available at your center, it should not deter you from managing children with COVID. You can still manage them with your care which you have at your center. If CT is done, then the common CT findings would include a ground glass opacities, consolidation, which are of bilateral peripheral distribution involving the lower lobes. Next investigation is arterial blood gas. Again, this has been taught already in detail on day 2. APG in ARDS typically shows hypoxemia with elevated AADO2. Capital A stands for alveolar and this stands for arterial. So the alveolar oxygen content is high, but arterial oxygen content is low because the diffusion across the alveoli is not happening. So AADO2 would be high. If the child starts developing fatigue, so then hypercapnia may start and child will develop hypercapnic respiratory acidosis. And this is an ominous sign indicating that child is developing respiratory fatigue. And he may start to have CNS manifestations and may die if interventions are not carried out appropriately. If ABG is showing metabolic acidosis, it means that child is developing sepsis, septic shock, or he has developed AKI, or there is tissue injury because of hypoxia. So these are the abnormalities you can get. You can get hypoxemia, you can get metabolic acidosis, and you can get hypercapnic respiratory acidosis, which is an ominous sign. So clinical monitoring along with serial ABG is important for managing children with ARDS. So once you have diagnosed severe COVID-19 in any child, first thing you do is admit that child in your COVID PICU. You give respiratory support, you give pharmacological treatment, which would include steroids with or without remdesivir. You start empiric antibiotics and restrictive fluid therapy. So by restrictive fluid therapy, we mean that don't keep on giving fluid boluses. You can give maintenance fluid at 75% of the TFR, total fluid rate, because giving more fluids has been seen to exacerbate the lung damage in ARDS. So follow restrictive fluid therapy. So this is the again algorithm proposed by or given by the Ministry of Health and Family Welfare. This summarizes the pharmacological treatment for severe COVID-19 in children. The drugs which we have to use include remdesivir and steroids. Now, remdesivir should only be used in hospital setting. You should never prescribe remdesivir for outpatient scenario, always in hospital settings. It should be used in restricted manner because at best its efficacy is modest. It is not a miracle. It does not work wonders. It is not recommended in children less than 18 years by the DGHS, but Indian Academy of Pediatrics still recommends it. But the benefit is maximum in the initial days of illness, in the initial 1 week of illness when the viral load is high. And if the child is in his second week of illness, then the benefit of remdesivir is only marginal. So the guidelines would recommend that do not use if the day of illness is beyond day 10. Use it only if the day of illness is within 10 days. Dose is for 3.5 to 40 kg, 5 milligram per kg on day 1 and 2.5 mg per kg from day 2 to day 5. For children who weigh more than 40 kg, the dose is 200 mg on day 1 and 100 mg from day 2 to day 5, which is the adult dose as well. Use it within 10 days of onset of symptoms and the child whose oxygen parameters are worsening rapidly, or if the child has severe COVID pneumonia. It is contraindicated if AST and ALT are above 5 times the upper limit of normal, or if the creatinine clearance is less than 30 ml per minute. The next drug which has to be used in severe COVID pneumonia is steroids. So you can choose either dexamethasone or methylprednisolone. Both are almost equally efficacious. You can choose either of them. Dexamethasone, the dose is 0.15 mg per kg per dose twice daily. Methylprednisolone 0.5 to 1 mg per kg per dose twice daily. Steroids have to be used for 5 to 14 days depending on continuous clinical assessment. If you use it for 14 days, then you may have to then slowly taper off over next 7 days. If you use it only for 5 to 10 days, then it can be stopped abruptly. Next class of drugs is antimicrobials. Now, COVID pneumonia is viral. Antibiotics are not going to help. Okay, but the thing is, you may not be able to differentiate bacterial pneumonia from viral pneumonia. So most of us use antibiotics for severe pneumonia, even if the COVID RT-PCR is positive. Although there may not be any evidence to support this, but we feel that using antibiotics, if we are missing some bacterial pneumonia, then that can be covered by antibiotics. But the dictum here would be use first-line antimicrobials. Don't start with carbapenems. Don't start with piperacillin tazobactam. Start with something like amoxicillin, ceftriaxone, which are the drugs which we use for community-acquired pneumonia. Next is respiratory support for severe COVID. The options which are available include nasal prongs, simple face mask, a non-rebreathing mask, high HFNO, NIV or CPAP, and invasive mechanical ventilation. So all these have already been discussed on day 2 and day 3 of the present teaching module. The target SpO2 which we want to achieve is during resuscitation of more than 90% and 94%, and once the child has stabilized, anything above 90% should be acceptable to us. You can consider awake prone positioning in older children, but maintaining a prone position in younger children may be difficult. So don't force a baby to lie prone. If he's more comfortable in supine position, then that is acceptable. But for adolescents, you can try maintaining them in prone positioning because that would improve the oxygenation to the lung regions. Now coming to management of ARDS in COVID, the mild ARDS, the target SpO2 which we should aim is between 92 to 97%. For mild ARDS, we can start with HFNO or NIV. If it fails, then we'll have to intubate and ventilate. For moderate to severe ARDS, the target SpO2 is between 88 to 92%. For children with moderate to severe ARDS, intubation and mechanical ventilation will be required because without that, they would develop hypoxemia. This diagram shows the stepwise management of hypoxia in COVID. The first step is using low flow devices like nasal prongs, which can be used at flow rates of 1 to 6 liters per minute. And at this flow rate, we can achieve FiO2 up to 45% using a low flow device like nasal prong. If a child, now with nasal prong, the comfort level is maximum. Child's mouth is free, so he can still continue to eat. But if the child's hypoxemia is not responding to your oxygen with nasal prong, then you will escalate to Hudson mask or a non-rebreathing mask. Using an NRM, you can achieve a FiO2 of as high as 95% if the NRM is used at flow liters of 10 to 15 liters per minute. If even NRM is failing, then you can consider using high flow nasal cannula or non-invasive ventilation using a face mask. HFNC children are more comfortable as compared to BiPAP. BiPAP, typically younger children do fight a lot and they are not comfortable with using BiPAP. It can be used for shorter periods, but for longer periods, children tend to develop fatigue. HFNC, on the other hand, can be tolerated in a better manner, but HFNC do not provide a lot of positive pressure. So CO2 elimination with HFNC may not be very good, but with using BiPAP, you can take care of oxygenation as well as ventilation. If HFNC and NIV are also failing, then the last resort is using endotracheal intubation, which would mean using a mechanical ventilator to ventilate the child. Now, what are the indications for intubation and mechanical ventilation in severe COVID? Severe respiratory distress and the child is developing exhaustion. The child's sensorium is deteriorating, his GCS falling to less than 8 with threatened airway. Hypoxia, so this is the most common indication for ventilation in a child with severe COVID is hypoxia, saturation less than 85%, despite use of the previous devices. Severe ARDS and respiratory acidosis, which means CO2 has also built up. So for CO2 elimination, your HFNC, NRM, and will not help. BiPAP to an extent will be helpful, but if BiPAP is also failing, then for CO2 elimination, you would need to intubate and mechanically ventilate the child. Just 2 slides about basics of mechanical ventilation. Again, has already been discussed. Once you decide to use a ventilator, you should know your machine very carefully. There are 2 types of variables which you have to set. One is the control variables, which mean how you want the breath to be delivered. It can be either pressure or volume. So pressure modes and volume modes, you can choose either of the 2 which you are more comfortable with. And the second thing is how you fine tune the breath. So fine tuning is done by a set of variables which are known as phase variables, which include A, that is trigger. Trigger means how you want the breath to start. B is limit, how you want the breath to be delivered. C is cycling, how you want the breath to end. And B, the fourth is baseline variable, which is the positive end expiratory pressure, which is maintained throughout the respiration. So initial settings, once you have decided which control variable you want to use, which can be either pressure or volume, whichever you are familiar with, both have certain advantages and certain disadvantages. So you can choose either pressure or volume, whichever you are comfortable with. Next thing is choose your mode. So you want to use SIMV mode or the assist control mode. Again, both of them are quite similar, but assist control decreases the work of breathing more as compared to your SIMV mode. And both these modes are widely available in most of the mechanical ventilators. So this is a scalar diagram of assist control mode, and this is the scalar diagram of SIMV mode. So the difference here is in assist control mode, the only thing patient has to do is trigger. So each time the patient triggers, the ventilator takes over and delivers the breath. So you can see all these red arrows show that patient has triggered. Each time the patient triggers, the ventilator takes over and deliver the breath. So सारे breaths almost same होते हैं. जितनी बार भी patient ने trigger किया, उतनी बार ventilator breath deliver कर देगा. Giving you an example, you have a 4-year-old COVID ARDS breathing at a rate of 40 breaths per minute. If you are ventilating that patient on assist control mode, patient is breathing at 40. Even if you set a rate of say 20, ventilator is going to deliver all 40 breaths as control breaths. So जितनी बार भी patient trigger करेगा 40 times करेगा तो 40 breaths ventilator deliver करेगा. If the patient develops apnea, then this 20 rate which you have set is the backup. So at least 20 breaths to deliver होगा ही होगा. On the other hand, in SIMV, if you have set a rate of 20, then only 20 breaths will be delivered by ventilator. Only 20 breaths will be delivered by ventilator. The other breaths, ventilator is not going to touch. So these are spontaneous breaths which ventilator will not do anything, allow the patient to breathe. Only the set breaths, जैसे आपने अगर 20 set किया है, तो 20 breaths would be delivered by the ventilator. Other 20 patient is going to breathe on his own without any help from the ventilator. So for ARDS, where you want to reduce the work of breathing, I would typically suggest using the assist control mode, because here the work of breathing would be decreased to a greater extent than the SIMV mode. SIMV mode can be used as a weaning mode once you have decided to wean the patient off ventilator. Now there is a hybrid mode which is again very commonly used. The mode which is most popularly used in our PICUs is SIMV plus pressure support. So in SIMV what was happening was the ये बीच के जो breaths है उनको हम untouched छोड़ दे रहे थे. They were not touched. In SIMV plus pressure support, these remaining breaths would be supported by the ventilator. They won't be controlled, but some amount of pressure support will be provided. So this is a hybrid mode. जिसमें mandatory breaths को SIMV मिल रहा है और बाकी spontaneous breaths को pressure support मिल रहा है. So it's something midway between assist control and plain SIMV plus pressure support. So you can use this as your initial mode as well as weaning mode. So advantage of SIMV plus PS is आपको मोड चेंज करने की जरूरत नहीं पड़ेगी. आप इसी से स्टार्ट भी कर सकते हैं और जब वीन करना होगा तो इसी मोड पे आप वीनिंग भी कर सकते हैं. Another mode which is commonly used is CPAP plus PSP, but it should not be used as initial mode. अगर ARDS में पेशेंट है, आप इस मोड से कभी भी इनिशिएट नहीं करेंगे. This is a weaning mode. ARDS resolve हो गया है. You are planning to wean the child, extubate the child. Then only you are going to use CPAP plus PSP. This should never be used as initial mode in ARDS because work of breathing कम नहीं होगी. The ventilator support is not optimal. Coming to initial settings. Now you have decided to ventilate your patient. What initial settings you are going to use? So choose your mode, either pressure or volume, SIMV plus pressure support or assist control. Any of them, both of these can be used. Choose a tidal volume. So we have to start with low tidal volume. So tidal volume which we should choose is 6 ml per kg. If we use a higher tidal volume, that is going to cause barotrauma. Lung की compliance poor है. अगर आप वॉल्यूम ज्यादा देंगे तो pressures which would develop, the plateau pressures would be very high. That would damage the alveoli. So we would use low tidal volume ventilatory strategy, that is 6 ml per kg. If we are using a pressure mode, then start with a PIP of 20 to 22 centimeters of water. And if you are using the pressure mode, monitor what tidal volume is being delivered. If you use volume mode, then monitor what plateau pressures are being delivered. Okay, so अगर आप volume mode use कर रहे हैं तो आप plateau pressure monitor करेंगे. आप pressure mode use कर रहे हैं तो tidal volume आपको monitor करना पड़ेगा. PEEP, you have to keep a PEEP a bit higher because the child has hypoxemia. So start with a PEEP of 8 to 10. If your target SpO2 is not achieved, you will have to increase the PEEP further till your target saturation is achieved. Start with a high FiO2 of 100%, and once the target SpO2 is achieved, FiO2 has to be gradually reduced. The respiratory rate has to be set physiological as per the child's age, and TI also physiological as per the child's age. Prefer using a cuffed ET tube because leak would be minimum if you use a cuffed tube. So always try to have cuffed ET tube. Cuffed ET tubes सारे sizes में now available हैं. You can use them. For older children, it is easily available. For younger children, it is a bit expensive. If you can get them, then prefer using a cuffed ET tube because the chances of air leak would be minimum. After starting ventilation with that initial ventilatory settings, you will have to modify your ventilatory setting based on the response. So you put a child on mechanical ventilator, monitor his SpO2, monitor the ventilatory parameters, and then you will have to do either of these two things or both of them. You may have to change settings to improve oxygenation. So अगर उसका saturation या PO2 improve नहीं हो रहा है तो आपको ये set of changes करने पड़ेंगे. If the child is developing CO2 buildup or respiratory acidosis, then you will have to do these set of changes. For improving oxygenation, the most effective strategy is increasing the PEEP. So PEEP बढ़ाने से mean airway pressure बढ़ जाएगा, and that is the most effective strategy for improving oxygenation. Other things which can be tried is increasing the tidal volume, but again this would cause barotrauma. Increasing the TI, but beyond a certain physiological time, you cannot keep on increasing DI. Okay, increasing the IE ratio again cannot be made unphysiological. So, and increasing the FiO2. Of all of these, increasing PEEP is the most effective strategy to improve oxygenation. For improving CO2 elimination, so CO2 elimination is a product of, is directly proportional to minute ventilation, which is product of tidal volume on respiratory rate. So अगर आपको CO2 elimination बढ़ाना है, increase the tidal volume or increase the respiratory rate. So these, any of these two things can be done to increase CO2 elimination. Now, few concepts of mechanical ventilation in ARDS. First is permissive hypercapnia. So once you are ventilating a child with ARDS, you have to be gentle in your ventilation. You cannot keep on increasing settings to achieve ideal blood gas. You have to reach something which is called acceptable blood gas. So acceptable means you have to accept high PCO2 values, PCO2 of 55, 60, anything is acceptable as long as pH is above 7.2. So जब तक pH 7.2 से कम नहीं हो रहा है, accept high PCO2 values. Don't keep on increasing settings to achieve a normal CO2, because by doing that you can cause barotrauma and air leak. नहीं तो patient को pneumothorax हो जाएगी अगर आप ideal CO2 के लिए tidal volume को बढ़ाते चले जाएंगे. Sedation and analgesia. Children will not feel comfortable with on ventilation with these settings. So you need to sedate them. You need to give analgesia to them. So for sedation, we would use midazolam. It can be initiated at 1 to 2 microgram per kg per minute, and dose can be titrated up or down as per the need of a particular child. For analgesia, you can use fentanyl infusion at 0.5 to 2 mics per kg per hour. Again, dose can be titrated to achieve the desired effect. Some patients, especially adolescent patients, may require neuromuscular blockade with vecuronium infusion, but it is not indicated routinely. It has to be considered only if you are unable to achieve synchronous ventilation with proper doses of midazolam and fentanyl. Okay, so patient का hypoxemia ठीक नहीं हो रहा है, patient fight कर रहा है, आपने midaz और fentanyl infusion start कर लिया है, then you may consider using vecuronium infusion for short periods of time. Transfusion threshold. So for PRBC has to be transfused if hemoglobin is less than 7 gram per DL. So hemoglobin का जो हम cutoff use करेंगे, that would be 7. But if the child also has unstable septic shock, then you will have to keep his hemoglobin above 10. So 7 से कम पे आप generally transfusion avoid करते हैं, और अगर shock में है तो 10 से कम पे आप transfusion करें. Prone ventilation, which is being shown in this diagram. Prone ventilation is difficult to achieve in younger children, but can be tried in 12 to 18-year-old. But you have to be very careful कि जो इतनी सारी tubings हैं accidentally disconnect नहीं हो जाए. Be very careful. If there is any alarm from the ventilator or from the monitor, go and see that all the circuits are properly connected. What monitoring has to be done in a child with ARDS? On his clinical monitoring, you will monitor his heart rate, respiratory rate, blood pressure, saturation, the consciousness, urine output. These have to be recorded every 2 hourly. You must keep a monitoring sheet in the PICU where you would chart these vital parameters on the chart. Lab monitoring, you would need ABG 1 to 2 times a day. And on SOS basis, aim for the adequate, not normal gases. Chest X-ray would be needed on SOS basis. Now, X-ray is needed to see what radiological improvement is happening. Sometimes X-ray is needed to look for any pneumothorax. But if a child is on high ventilatory settings in ICU, develops pneumothorax, then the chances of tension pneumothorax is extremely high. In such scenarios, don't wait for X-ray to do any intervention. You have to diagnose tension pneumothorax on bedside and do a needle thoracocentesis at the bedside, because if you wait for X-ray, the child may develop cardiovascular collapse and may die even before your X-ray machines comes there. So child on high ventilatory settings, pneumothorax कभी भी हो सकता है. उसको कैसे डायग्नोज करना है, आप क्लिनिकली पता होना चाहिए कि चेस्ट का मूवमेंट कम हो जाएगा, हाइपर रेजोनेंट नोट होगा और आप ऑस्कल्टेट करेंगे तो साइड एयर एंट्री नहीं आएगा. अगर ऐसी फाइंडिंग्स हैं, पुट अ नीडल इन द सेकंड स्पेस अंडर वाटर सील. इफ कंटिन्यूअस बबलिंग आ रही है, इट मींस द चाइल्ड हैड pneumothorax. Inflammatory markers will be needed every 24 to 48 hours early to look for the hyperinflammatory state में improvement आ रही है या नहीं. Ventilatory monitoring, look for chest rise, look for retractions, monitor the plateau pressure in the ventilator screen, monitor the minute volume in the ventilatory screen, and set your alarm limits properly, because कई बार आप ICU में जाएंगे, you'll see कि सारे alarms बजते जा रहे हैं. This happens because we have not set the alarm limits properly. अगर हम alarm limits को सही से set करेंगे, तो alarm तभी बजेगा जब उसको बजना चाहिए. So set those alarm limits once you have started ventilation. Avoid frequent circuit disconnection. If you have access to inline suction catheters, use them. If you don't have access, then don't do any routine suctioning कि हर 2 घंटे पे हर 3 घंटे पे आप suction कर रहे हैं. So that is going to cause de-recruitment. सारे alveoli जो है, अगर आप circuit disconnect करेंगे, the alveoli would collapse. So avoid frequent circuit disconnections just for routine suctioning. Suctioning has to be done only if you are seeing secretions in the ET tube or child is developing hypoxemia and you are not able to ascertain any cause for that hypoxemia. You are suspecting कि tube blockade है, तभी आप उसको suction करेंगे. Also monitor for sedation adequacy, and daily morning, once the staffing of ICU is adequate, discontinue sedation for 1 hour to monitor the child's sensorium. Okay, so सुबह के राउंड के समय आप 1 घंटे के लिए उसकी sedation बंद करके assess what the child's sensorium is. So in the last, we'll just see a case scenario to learn whatever we have discussed till now, to revise. Okay. So we have a 6-year-old COVID positive girl who arrived in the emergency department. The child was unwell for 7 days. She had fever, cough, and progressive respiratory distress. When she came to the emergency, she was agitated. Her airway was clear. So she was conscious, airway was clear, but she was agitated. She had severe respiratory distress. Her saturation on high flow nasal oxygen at 30 liters per minute with a FiO2 of 100% was only 84%. So this child had hypoxemia and clearly she is failing the HFNO. Her heart rate was 170. She had tachycardia. Her blood pressures were normal. She had warm peripheries and she had a ABG which was showing a pH of 7.47, CO2 slightly low, and she had hypoxemia. So low PO2 with some CO2 washout. So respiratory alkalosis with hypoxemia, even the saturation is low, and you can see her X-ray. There are bilateral infiltrates. So we made a diagnosis of ARDS due to COVID-19 in this child. We had the option of using BiPAP, but because the child was so agitated, we decided not to use BiPAP. We decided to intubate and mechanically ventilate this child. Now for intubation, always follow the rapid sequence intubation algorithm. So pre-oxygenate, use atropine, use sedation, and then intubate. Your child should not be fighting when you are intubating the child, because fighting would further worsen his or her hypoxemia and she may develop cardiovascular collapse during your intubation. So pre-oxygenate, sedate, use atropine, and then intubate. After intubation, you have to decide what initial settings we are going to use. So in this child, we decided to use volume assist control. We used a tidal volume of 6 ml per kg. So she was 15 kg. We used a tidal volume of 90 ml. We started with the PEEP of 8, physiological respiratory rate of 20, TI again physiological of 0.8, and started FiO2 of 100%. Along with this, we used midazolam and fentanyl infusion. We managed without vecuronium, and the child was not agitated and fighting after using midaz and fentanyl. So with this setting, we started ventilation. But because the child was not improving, the hypoxemia was persisting, we gradually escalated her PEEP PEEP till 16 hours. At 16 of PEEP, child's hypoxemia subsided, her saturation improved. After that, we gradually reduced her FiO2 to the present value of 60%. So child is now stable on V assist control mode, tidal volume 6 ml per kg, PEEP of 16, respiratory rate of 20, TI of 0.8, and FiO2 of 60%, along with good sedation and analgesia. With these settings, so itna zyada jab PEEP hai, so keep a watch on plateau pressures. Plateau pressure should not be allowed to go above 30. Agar 30 ke upar ja raha hai, the risk of barotrauma would be very high. You may have to reduce the tidal volume further. Once patient has stabilized, then we have to consider weaning this child. So weaning के लिए इस बच्चे में again ये आपको already पढ़ाया जा चुका है. We'll start reducing the PEEP further. 16 से हम उसको 14 करेंगे, then 12 करेंगे, then 10 करेंगे. जब PEEP reasonable हो जाएगा, then we'll have to change his mode as well. Mode अगर हमने volume assist control से start किया है, इस पे हम weaning नहीं हो सकती है. We will change the mode to SIMB. SIMB allows the patient to breathe on her own. SIMB पे जब शिफ्ट हो जाएगा, then we'll start reducing the rate. Rate को हम 20 से कम करना शुरू होंगे, 18, 16, 12, 10. जब इस पे भी patient tolerate करने लगेगा, then we would move to a spontaneous mode, which is CPAP plus PSV. So CPAP plus PSV is a weaning mode. We'll switch to that mode if the child is tolerating even on this mode. We'll give a spontaneous breathing trial. Patient spontaneous breathing trial we pass kar jayega, then we can consider extubation of that child. So just to summarize, the take home message from this presentation is managing a child in your COVID PICU, focus on the basics, focus on infection prevention, focus on nutrition, focus on your fluid management, because ventilatory, only a small proportion of your patients are going to require ventilatory care. Majority would improve without ventilatory care. So ये जो basics है, hospital acquired infection बचाना, nutrition देना is very, very important. Drugs like steroids, remdesivir, low molecular weight heparin, none of them is a miracle. Right patient, right time will do the trick. So choose your patient carefully. किस patient में कौन सा drug use करना है. Overuse of any drug can be harmful. अगर आप mild patients में steroids use करने लगेंगे तो आपको steroid की toxicity मिलने लग जाएगी. 10 days के beyond remdesivir is of no use. So don't use drugs unjudiciously. Ventilation is a blend of art and science. Spend time with the patient and with the machine. जब patients नहीं हैं, आप अपने ventilators को देखिए, practice करिए. हर ventilator के साथ एक manual आती है, which is extremely detailed. उस ventilator के बारे में हर mode की जानकारी उस manual में होती है. So go through that manual. Practice on the machine without a patient. So तभी you will become worse with your machine. And once you have patient in your ICU, spend time with the patient. Look carefully at all the parameters. Ventilate gently and with low tidal volumes, because high tidal volume causes barotrauma. Aim for acceptable gases, not normal, because normal achieve करेंगे तो again ventilator induced lung injury हो जाएगी. And always communicate with the relatives. If patient is extremely critical, communicate with the relatives. They should be prepared for the adverse outcome in advance. So these are the sources and these are the guidelines which you can go through. All this matter of the presentation was taken from these learning materials. Thank you. So if there are any questions, then I would be happy to answer.
Thank you, Dr. Nishant, for such a explained and such a wonderful presentation. So there is one question I'm able to see in the question answer.
So when to start steroids, from which day of illness? So for this again, if you have diagnosed severe COVID pneumonia, then you have to start steroids from that day itself. The day you diagnose severe COVID disease, you will start steroids from that day itself. For mild, it is not indicated. For moderate, if the child's oxygenation is worsening, then again you can consider using steroids. So one, Dr. Soumya has asked, please explain PEEP and what is normal in ventilatory settings and also FiO2. So I was talking about ARDS. So in ARDS, the most important thing to address is hypoxemia. And as I showed you in the diagram, that improving hypoxemia, PEEP is the most effective strategy. So अगर आप PEEP बढ़ाएंगे तो PaO2 improve होगा. और ARDS में हाइपोक्सिया होता है, इसलिए हम PEEP थोड़ा ज्यादा स्टार्ट करते हैं. We start with 8 to 10. अगर non-ARDS lungs है, we start with the physiological PEEP, which is 5. In ARDS, we start with 8 to 10 and then gradually increase the PEEP till we achieve the normal saturation level. So जब achieve हो जाता है तो PEEP को gradually कम करना शुरू कर देते हैं. FiO2 हम 100% से स्टार्ट करते हैं. जैसे ही हमारा टारगेट अचीव होता है, FiO2 PEEP से पहले कम करना शुरू कर देते हैं. पहले FiO2 को हम 60% तक लाएंगे, उसके बाद PEEP को कम करना शुरू करेंगे. Calorie requirement would be taught in next lecture by Dr. Adisha. Ventilation is CO2 elimination, which is product of tidal volume and respiratory rate. अगर आपको CO2 elimination improve करना है, you can increase the respiratory rate or you can increase the tidal volume. इन दोनों में से क्या आप चूज करेंगे, that would depend on a given patient. अगर आपने रेट फिजियोलॉजिकल रखा है तो आप पहले रेट बढ़ाइए, बिकॉज टाइडल वॉल्यूम बढ़ाने से बैरोट्रॉमा हो जाएगा. अगर रेट ऑलरेडी आप हाई अचीव कर चुके हैं, तब भी CO2 रिटेंशन हो रहा है, परमिसिव हाइपरकैप्निया भी नहीं है, मतलब pH भी 7.2 से कम है और CO2 बिल्डअप हो रहा है, तब आप टाइडल वॉल्यूम उसका इंक्रीज करें. I think that would be all.
Okay, so now we are moving ahead towards the next lecture, which will be taken by Dr. Neeraj Anand, who is also a faculty in Department of Pediatrics, King George Medical University. And Dr. Neeraj Anand will be talking about the septic shock and the intravenous access. So Dr. Neeraj Anand, please start.
And good afternoon to all the panelists as well as delegates. Today we are going to discuss about septic shock, especially in case of present COVID era. Is my screen visible?
Yes, visible, audible, please start.
Thank you, ma'am. So today we are going to discuss about septic shock in pediatric patients. And as we are going towards third wave in current COVID era, so there are increased chances of MISC patients as well as normal COVID patients. So the COVID patients may present with diarrhea as well as vomiting, which may land up the patient in hypovolemic shock, or the patient of MISC may have myocarditis as well, which may present with cardiogenic shock, or if the patient is on ventilator and due to increased PEEP, there may be tension pneumothorax, which may lead to distributive shock, or the patient might have pneumonia with viral pneumonia, which may have additional secondary bacterial infection, which may ultimately lead to septic shock in these patients. So we are going to discuss about different type of shock in pediatric patients and how to manage these patients. So at the end of this class, the participants should be able to recognize the type of shock. First of all, recognize that the patient is in shock, and second, the patient participants should be able to recognize different type of shock in the patient. Participants should be able to plan fluid therapy appropriate for different type of shocks, and when to start vasopressors and inotropes in case of shock. So coming on to the definition of shock, shock is defined as a state of significant systemic reduction of overall blood flow to the tissues, and hence failure to deliver adequate oxygen and nutrient to meet its need. So in shock, there is increased demand and there is decreased supply of blood, as well as through blood, the metabolic demands as well as oxygen demand is not met to different tissues. In shock, there is also inefficient removal of byproducts of cellular metabolism, which also may lead to different organ dysfunctions. Now, coming on to the definition, how do we define severe sepsis? So, severe sepsis is defined as a life-threatening organ dysfunction which is caused by a dysregulated host response to infection. So, it is basically body's immune response which ultimately leads to multi-organ dysfunction along with bacterial toxins that are released. Septic shock is defined as a sepsis when sepsis is associated with cardiovascular dysfunction, that is the patient is having hypotension requiring vasopressors, then it is known as septic shock. So septic shock is basically a subset of sepsis with circulatory as well as cellular and metabolic dysfunction associated with higher risk of mortality. Now coming on to the pathophysiology. Due to inadequate perfusion, there is the oxygen as well as nutrient supply to the cell is decreased, which ultimately lead to cell hypoxia. Due to cell hypoxia, there is shift of efficient aerobic metabolism to less efficient anaerobic metabolism, which ultimately leads to energy deficit. In anaerobic metabolism, there is also lactate production, which ultimately leads to lactic acid accumulation and fall in pH. So ultimately causing metabolic acidosis. As cell membrane as well as other enzymes are pH dependent in cell, so there is cell membrane dysfunction, and along with it, there is failure of sodium pump. So it leads to intracellular lysosomal enzyme release as well as digestive enzyme release into the circulation. These toxic substances ultimately leads to capillary endothelial damage and damage to different organs, which ultimately leads to multi-organ dysfunction and death in the patient. All type of shock goes through stages of compensated shock. Then if not managed at this stage, then ultimately it goes to decompensated shock. In compensated shock, the blood pressure is preserved, the patient is not hypotensive. In decompensated shock, there is associated hypotension. And if not managed at this stage also, the patient will ultimately lead to irreversible damage to different organs and tissues, with ultimately leading to irreversible shock. Now, how do we differentiate clinically between different type of shock? On the basis of history, if the patient is having a history of GI losses, such as the patient is having history of diarrhea and vomiting, or if the patient is having history of hemorrhage, then the patient might be in hypovolemic shock. If the patient is having history of anaphylaxis, or if there is history of any infectious focus in the body, such as if there is patient is having pneumonia or UTI, then the patient might be and the patient is presenting with shock, then the patient might be in septic shock. Or if there is history of trauma to the spinal cord, then the patient might be in neurogenic shock. If the patient is having history of congenital heart disease, or history as well as examination as well as investigation if suggestive of cardiomyopathy or arrhythmias, then the patient might be in cardiogenic shock. If the patient is having history examination suggestive of tension pneumothorax or cardiac tamponade or duct dependent lesion, then the patient will be in obstructive shock. Now, in all type of shock, tachycardia will be a common features. In hypovolemic as well as in case of distributive shock, the patient will have quiet tachypnea. That is, the tachypnea will not be associated with increased work of breathing. But in case of septic shock, the patient, if having additional, if the patient is having pneumonia, then the patient might have increased work of breathing in cases of septic shock. In cases of cardiogenic shock, as the patient is having pulmonary edema, then the patient will have tachypnea along with increased work of breathing. In case of hypovolemic shock, the patient might be in hypotensive, or the BP may be normal, but the pulse pressure will remain normal in case of hypovolemic shock. Whereas in case of septic shock, there will be wide pulse pressure with bounding peripheral pulses. The BP may be normal, or the patient may be hypotensive. In case of cardiogenic shock, there will be narrow pulse pressure and the patient might be in hypotension or the BP might be normal. In patients of hypovolemic shock as well as cardiogenic shock, the capillary refill time will be delayed. In case of septic shock, especially if the patient presents with warm shock, there will be flash capillary refill. That is, the capillary refill time will decrease the capillary refill time will be less than 1 second. In all type of shock, in advanced stages, once the blood supply to the brain is hampered, the patient will present with altered mental status. Oliguria, which is a marker of decreased internal organ perfusion, is common to all type of shock. In case of warm shock, there will be warm and flushed extremities, whereas in case of hypovolemic as well as cardiogenic shock, the patient will have cold extremities. There will be adverse response to fluid challenge, especially in case of cardiogenic shock. In case of hypovolemic shock, there will be favorable response to fluid. And in case of septic shock or anaphylactic shock, there will be associated symptomatology. That is, in anaphylactic shock, the patient will have additional stridor or wheeze, and there will be a history of allergy. Now, coming on to the different parameters, how they change in different type of shock. In hypovolemic shock, as the blood volume is decreased, so the patient will have decrease in preload. Cardiac contractility will remain normal. Due to compensatory mechanism, there is increase in peripheral vascular resistance, which ultimately leads to increase in afterload. Capillary refill time will be prolonged. Mixed venous saturation, which is a marker of increased oxygen extraction at the tissue level, will be low in case of hypovolemic shock. In case of cardiogenic shock, the primary pathology is there is decrease in cardiac contractility. The patient will have increased preload. There will be increase in afterload, and there will be increased capillary refill time. Mixed venous saturation will be low. In case of distributive shock, venous tone is decreased. There is peripheral blood pooling. So this ultimately leads to decrease in preload. As there is vasodilatation, so ultimately it leads to decrease in peripheral vascular resistance. So this leads to decrease in afterload in case of distributive shock. Capillary refill time will be decreased. That is, there will be flash capillary refill initially. Mixed venous saturation is high. In obstructive shock, as the heart is not able to properly relax, so there is increase in preload. Cardiac, as in case of cardiac tamponade or tension pneumothorax, the heart is compressed, so there will be decreased cardiac contractility. There will be increase in afterload, increase in capillary refill time, and increase in mixed venous saturation in these patients. So if a patient comes to emergency, we have to assess the patient rapidly by this pediatric assessment triangle, in which we rapidly assess for appearance, breathing, and circulation. In appearance, we look for signs and symptoms of decreased organ perfusion, especially CNS manifestations. So if the patient is having reduced muscle tone, decreased mental status, weak cry, there is decreased responsiveness, or purposeless or vacant stare, and if the child is unable to recognize his parents, or if there is poor response to painful stimuli, these all are indicators that the patient might be in shock. We have to look for breathing, whether there is effortless tachypnea or if there is increased work of breathing. So effortless tachypnea that might be seen in case of hypovolemic shock or in case of anaphylactic shock. In anaphylactic shock, there will be additional stridor and wheeze in case in these patients. Increase of work of breathing is seen in case of cardiogenic shock, or if the patient is in septic shock with associated pneumonia, or if the patient is having tension pneumothorax. So in all these cases, there will be increased work of breathing. We have to look for circulation. So if there is circulatory failure, the patient will have cold extremities, mottled appearance, acrocyanosis, and pallor. Now, we have to look for capillary refill time. If capillary refill time is more than 2 seconds, it suggests that there is vasoconstriction and the patient will be is in cold shock. If the capillary refill time is less than 1 second, then the patient will be in warm shock or distributive shock. Blood pressure is not required to define shock in pediatric patients. Blood pressure might be normal, low, or even increased, especially in case of neurogenic shock. Mental status, there is altered level of consciousness, and if there is decreased level of consciousness, it indicates that there is CNS involvement, and it is an ominous sign. Urine output, which is a reliable indicator of internal organ perfusion. So if there is decrease in urine output, it indicates that the patient is in shock. Now, to define the patient is having hypotension or not, that is the patient is having whether having compensated shock or decompensated shock. We have to look for normal blood pressure centile charts. So if the blood pressure is less than 5th centile, then we say that the patient is having hypotension. So in a term neonate, if the blood pressure is less than 60 millimeter of mercury, or in an infant 1 month to 12 months of age, if the BP blood pressure is less than 70 millimeter of mercury, or in a child of 1 to 10 years of age, blood pressure, systolic blood pressure, if less than 70 millimeter of mercury plus 2 into age in years. So if the child is of 5 years of age and systolic blood pressure is less than 80 millimeter of mercury, it means that the patient is having hypotension. If the patient is 10 years or older and blood pressure is less than 90 millimeter of mercury, it indicates that the patient is in hypotensive stage. Now we have to classify the shock, whether the patient is having cold shock or warm shock. It is important for management point of view. If the patient is having cold extremities with normal blood pulse pressure with thready pulses, it means that the patient is having cold shock. If the pulse pressure is increased, that is wide pulse pressure having bounding pulses with warm peripheries, it means the patient is in warm shock. Now coming on to the management, we have to increase the oxygen delivery and decrease oxygen demand. So for all children in all type of shock, we have to provide oxygen. We have to start with 100% oxygen and titrate according to saturation. We have to give fluid according to type of shock, amount as well as type of fluid. Temperature, we have to manage hypo or hyperthermia. We have to correct metabolic abnormalities if the patient is having hypoglycemia or hyperglycemia, or if there is an electrolyte abnormalities. Depending on suspected cause, if the patient is having septic shock, we have to start antibiotics within 1 hour. If the patient is not responding to fluid alone, we have to start inotropic therapy. And if the patient is unconscious or GCS is low, then we might have to start mechanical ventilation. Mechanical ventilation decreases work of breathing, and also it redistributes blood to vital organs. Airway, if not protected, or if the patient is having low GC and patient is not able to maintain his airway, then we might have to intubate the patient and ventilate. Breathing, we always start with 100% oxygen and we monitor for saturation and titrate the oxygen requirement as per the saturation of the patient. Circulation, we have to establish IV access rapidly, and if we cannot access intravenous access within 90 seconds, then we have to go for intraosseous cannulation. We have to monitor the patient by looking for capillary refill time and frequent blood pressure monitoring. Laboratory investigations, what we have to do, we have to do ABG, arterial blood gas analysis, to look for any hypoxia or hypercarbia, or if there is any metabolic acidosis, or if the patient, we have to look for lactate levels. We have to look for blood sugar if the patient is having hypoglycemia or hyperglycemia. We have to correct electrolyte abnormalities We have to look for hypercalcemia or potassium levels as well as sodium levels. CBC to look for infection, PTA, PTT, if the patient is having bleeding tendencies. Type and cross matching is to be done, especially in case of hemorrhagic shock. Cultures to look for focus of infection, especially in septic shock patients. So coming on to the intraosseous access. Intraosseous access, the important indications for intraosseous access is if we could not gain IV access within 90 seconds in a patient of shock, or if the patient is presenting directly in cardiac arrest, or if the patient is having decompensated shock. So we have to go for intraosseous access. It could be removed when the venous access is available. The equipment required for intraosseous access include alcohol swabs, povidone iodine, 18 gauge needle with trocar with at least 1.5 centimeter needle length, 5 ml syringe, 20 ml syringe, infusion fluids, analgesia, anesthesia or sedation may be required if the patient is conscious and fighting. We have to identify the appropriate site for intraosseous access. As we can see in this figure, the appropriate site could be proximal tibia or distal tibia or distal humerus. So in proximal tibia, anteromedial surface 2 to 3 centimeter below the tibial tuberosity. In distal tibia, the site could be proximal to the medial malleolus. In distal femur, in midline 2 to 3 centimeter above the external condyle. So on all these 3 sites, we could try for intraosseous access. So first of all, we have to prepare the skin by using spirit, then povidone, then again spirit. We have to clean at least 5 to 10 centimeter of area. Then we have to insert the needle through the skin through a screwing motion perpendicular and slightly away from the epiphyseal plate into the bone. Once we have entered the marrow cavity, there will be sudden decrease in resistance. This is known as a feeling of giveaway, and this means that we have entered the bone marrow cavity. To confirm, we might aspirate the bone marrow. If marrow is not aspirated, we could flush 5 ml of saline. If it is having a free flow of saline, that means that we have entered the bone marrow cavity. We would secure the needle and start the infusion. The infusion has to be given manually with boluses of 20 ml per kg. Now coming on to the management of management fluid replacement, how to replace the fluid. We have to replace deficit fluid as well as maintenance fluid. Deficit fluid is basically fluid which is lost prior to the medical care. It's termed as deficit fluid. And maintenance fluid is given to replace the insensible water loss, which is lost through respiratory tract or skin. So deficit fluid could be either crystalloid fluids, which could be ringer lactate, normal saline or half normal saline. Colloids that could be used as a deficit fluid could be albumin, it could be dextran or hetastarch. Maintenance fluid is given according to Holiday-Sager method. So to calculate maintenance fluid, for initial 10 kilogram of weight, we give 100 ml per kg of fluid. For next 10 to 20 kg of weight, we give 50 ml per kg of fluid. And for weight above 20 kg, for every kg of weight, we give 20 ml per kg of fluid. So if a patient is of 22 kilogram of weight, so for initial 100 ml per kg of fluid, we will give 1000 ml. For next 10 to 20 kilogram weight, we will give 50 ml per kg, that is 500 ml. For next 2 kilogram weight, we will give 20 ml per kg of fluid, that is 40 ml. So the total fluid requirement will be 1540 ml for 24 hours. Now, what type of fluid is to be given in different type of shock? In case of hypovolemic shock, we have to give fluid boluses over 5 to 10 minutes, 20 ml per kg of fluid boluses is to given. If the patient is presenting with severe dehydration, in that case, fluids up to 100 ml per kg of fluid could be given. depending on the age of the patient, if the child is of less than 1 year of age, so the 100 ml per kg of fluid is further divided into 30 ml per kg and 70 ml per kg of fluid. So initial 30 ml per kg of fluid in child of less than 1 year of age, 30 ml per kg of fluid is to be given within 1 hour, and next 70 ml per kg of fluid is to be given in 5 hours. If the child is more than 1 year of age, initial 30 ml per kg of fluid is to be given within 30 minutes, and next 70 ml per kg of fluid is to be given in 2.5 hours. If the patient is having history of blood loss, so for every 1 ml of blood loss, we have to replace 3 ml of fluid. If there is no improvement even after giving fluid, we have to consider for packed blood cell transfusion. Albumin may be considered for additional IV volume infusion in case of shock, trauma, or burn patients. In case of cardiogenic shock, if the patient is having signs and symptoms suggestive of fluid overload, then we might have to start with diuretics and vasodilators. If there is any additional fluid requirement or if the patient is having showing signs of dehydration, then we might give small boluses of fluid of 5 to 10 ml per kg over a longer duration. So in this case, 5 to 10 ml per kg of fluid is to be given over 10 to 20 ml 20 minutes of time. In case of obstructive shock, we have to rapidly manage the cause of shock. If the patient is having tension pneumothorax, then we have to do needle decompression. If the patient is having cardiac tamponade, then we have to go for pericardiocentesis in these patients. Few patients might present with more than one type of shock, especially patient of septic shock may have hypovolemic shock with additional cardiogenic shock due to myocarditis. Now coming on to the septic shock. In septic shock, there is a dictum of golden hour. It means that if we rapidly manage the patient in initial 1 hour, for every 1 hour delay in the management of patient of septic shock, there will be approximately 7.6% increased chances of mortality with subsequent delay in management of septic shock. So we have to rapidly assess and manage patient of septic shock. We have to start supplemental oxygen, establish IV access, or if we cannot have IV access, then we have to go for intraosseous access. We have to administer bolus of 20 ml per kg of isotonic saline, or if it is not responding to that, we could go for colloids. So up to 60 ml per kg of fluid could be given in a patient of septic shock, or until the perfusion improves, or the patient is having signs and symptoms suggestive of fluid overload, such as hepatomegaly, raised JVP, or bilateral pedal edema. We have to correct hypoglycemia, and also we have to avoid hyperglycemia also. So blood glucose level should not go above 180 milligram per deciliter. We have to correct hypocalcemia. We have to maintain temperature. Anaphylactic shock, the drug of choice for anaphylactic shock would be adrenaline, which is to be given IM in case of anaphylactic shock, and we have to use crystalloid fluids as per requirement. In case of neurogenic shock, 20 ml per kg of fluid bolus is to be given over 5 to 10 minutes. Special consideration is to be given in case of pediatric patient, especially patient with severe acute malnutrition. No rapid fluid boluses has to be given, and only 15 ml per kg of fluid should be given over 1 hour under monitoring. During this period, we have to monitor for heart rate as well as respiratory rate. If there is increase in heart rate more than 15 per minute and increase in respiratory rate of more than 5 per minute, it means that there is fluid overload and we have to stop the fluid. If there is improvement in respiratory rate or with our heart rate, that means it is responding to fluid bolus and we may try another bolus. In case of SAM, the preferred fluid is ringer lactate with 5% dextrose, or N/2 saline with 5% dextrose. Now, how much fluid we could give depend on whether we have ICU care available or we do not have ICU care. If we could monitor the patient and we have ICU care, we could give fluid boluses up to 40 to 60 ml per kg with 10 to 20 ml per kg of each bolus over the first hour. If ICU care is not available and the patient is not in hypotension, then no fluid boluses is to be given. If the patient present with hypotension and ICU care is not available, we could give 10 to 20 ml per kg of fluid bolus, but only fluid bolus could be given up to 40 ml per kg over the first hour. Monitoring. So how do we know that we have achieved the goal? So we have to look for quality of central and peripheral pulses. Central as well as peripheral pulses both should be strong. Distal pulses should be equal to the central pulses. Peripheral skin perfusions, we have to look for peripheral skin perfusion. The periphery should be warm. The capillary refill time should be less than 2 seconds. We have to look for mental status. The patient should have normal mental status. Urine output should be more than 1 ml per kg per hour. Blood pressure, the patient blood pressure should be above 5th percentile. Now, if we have ICU settings, then we could monitor for serum lactate levels. Serum lactate levels should be less than 2 millimole per liter. We have to target mean arterial pressure. We have to restore and maintain normal perfusion pressure, defined as mean arterial pressure minus the central venous pressure for age. Central venous oxygen saturation should be greater than 70%. Cardiac index, which is equal to cardiac output divided by body surface area. So cardiac index should be between 3.3 and 6 liter per minute per meter square. Now, if the patient is not responding to fluid therapy alone, we have to start inotropic therapy in patients. So initial inotropic of choice in cold shock should be a vasoactive agent with an inotropic properties such as adrenaline. If adrenaline is not available, we may use dopamine. In case of warm shock, the drug of choice, the vasopressor of choice would be norepinephrine, as norepinephrine is a potent vasoconstrictor. It causes redistribution of blood from skin and other tissues to vital organs such as brain and heart. Regardless of the physiology and choice of agent, the peripheral inotropic support with epinephrine is found to be safe for short duration. Now, coming on to different inotropes, adrenaline act through all adrenergic receptors, whether alpha or beta. So it causes increased contractility, increase in heart rate, and increase in systemic vascular resistance at higher doses. So due to increased contractility, due to effect on beta-1 receptors and increase in heart rate, there is increase in stroke volume, which ultimately leads to increase in cardiac output. In case of adrenaline at low doses, the beta effect predominates. So at low doses, there will be decrease in systemic vascular resistance. So there will be increased heart rate along with increased cardiac contractility, which causes increase in preload, whereas decreased systemic vascular resistance will lead to decrease in afterload. So both these effects will lead to favorable effect in shock patient. At high doses, there will be increased systemic vascular resistance, which ultimately leads to increase in afterload. So at higher doses, there will be some negative effect of ADR. So we usually prefer ADR at lower doses. So normal doses would be 0.05 to 1 microgram per kg per minute. So how to prepare adrenaline infusion? An adrenaline ampule contains 1 milligram per ml of ADR. So we have to divide 0.3 into weight in kg. So if the patient weight is 10 kg, so 3 mg of ADR is to be mixed in 50 ml of 5% dextrose or 10% dextrose or normal saline, and 1 ml per hour of this solution means that the infusion rate is 0.1 microgram per kg per minute. So we could titrate the infusion rate by this method. Noradrenaline is a potent vasoconstrictor agent. It is a pressure agent which leads to intense vasoconstriction and increase in systemic vascular resistance. So it increases both systolic as well as diastolic blood pressure, especially in case of septic shock. If the patient is having warm shock, so due to vasoconstrictor effect, there will be redistribution of blood from peripheries to more important vital organs such as brain, kidney, and heart. So it will have beneficial effect in especially in warm shock. There is also some positive inotropic effect. So it causes increase in cardiac contractility, ultimately leading to increased stroke volume and increase in cardiac output. It has minimal positive chronotropic effect. And there is reflex bradycardia, which is advantageous, especially in patients with intrinsic tachycardia. Dose is same as adrenaline. Now coming on to the dopamine. Dopamine binds both to dopaminergic as well as adrenergic receptors. At low doses up to 5 microgram per kg per minute, it activates dopaminergic receptors, which leads to increased contractility of heart as well as increased contractility as well as vasodilatation, mostly in renal and mesenteric beds. So at low doses, there is no significant effect on shock. At 5 to 15 microgram per kg per minute, beta-1 effect predominates, which leads to increase in cardiac contractility, increase in heart rate, ultimately leading to increased cardiac output and systolic blood pressure, with minimal effect on diastolic blood pressure. So in routine practice, we use 5 to 15 microgram per kg per minute dopamine at this dose only. At higher doses, more than 15 microgram per kg per minute, the alpha effect predominates, which causes disproportionate vasoconstriction. So there will be increase in BP, but it is at expense of decreased cardiac output, as there will be increase in after load. So, and along with this, there will be increased cardiac oxygen consumption in these due to dopamine. So dose is 5 to 20 microgram per kg per minute. Dobutamine is a synthetic compound mostly with effect mostly on beta-1 receptors. So due to effect on beta-1 receptors, it causes increase in cardiac contractility. It also has effect on beta-2, which leads to vasodilatation and decrease in systemic vascular resistance. It has positive chronotropic effect, that is increases heart rate, so ultimately increases cardiac output. Therefore, there will be increase in cardiac output, which leads to increase in perfusion. It is good choice drug, especially in situation with poor perfusion and in high systemic vascular resistance due to vasoconstriction. So dobutamine may be administered or added to vasopressors in presence of myocardial dysfunction. So it is especially preferred in agent in case of cardiogenic shock. If there is persistent hypoperfusion despite achieving adequate intravascular volume and adequate mean arterial pressure. So if the patient is not responding to fluid therapy and not responding to vasoactive therapy, then we might consider for stress dose corticosteroid in these patients. Blood products, we have to transfuse packed RBCs if the patient is having hemoglobin less than 7 gram per deciliter in case of patients of hemorrhage, or if the patient is having severe hypoxemia, or if the patient is having signs and symptoms suggestive of myocardial ischemia. FFP is to be given if the patient is having deranged coagulation profile, or if there is any active bleeding, or if there is we are going for any surgical or invasive procedure and the patient is having deranged coagulation profile. Platelet transfusion, if there is no apparent bleeding and the platelet is less than 10,000, then we have to consider for platelet transfusion. If the patient is having significant risk of bleeding, so even if the patient is having counts less than 20,000, we have to consider for platelet transfusion. If the patient is going for surgery or any invasive procedure, or if the patient is having active bleeding, so we have to maintain platelet counts above 50,000 in these cases. Blood glucose level has to be maintained below 180 milligram per deciliter, but we have to avoid hypoglycemia. Antibiotics has to be started within 1 hour in case of septic shock patients. Diuretics may be used once fluid resuscitation has been given and the patient is having signs of fluid overload. Deep vein prophylaxis is not recommended. We have to prevent stress ulcers, and we have to start early enteral nutrition in these cases. Monitoring a child with septic shock, clinical parameters that we have to look in patient of shock is, we have to look for pulses, capillary refill time, state of hydration, peripheral edema, hepatomegaly. These are to look for any signs of fluid overload, toe to core temperature gap, heart rate and rhythm, jugular venous pressure. Jugular venous pressure is raised in case of fluid overload or cardiogenic shock. We have to do pulmonary and cardiac auscultation. Pulmonary auscultation is important. In case of cardiogenic shock or in case of fluid overload, the patient may have will have bilateral crepes. Respiratory pattern, whether there is effortless tachypnea or if there is increased work of breathing. Urine output, we have to look for whether we have achieved normal urine output or not. Mental status of the patient has to be monitored. Serial glucose monitoring, we have to manage the blood glucose level below 180 and avoid hypoglycemia. Electrolytes should be corrected if the patient is having hypo or hypercalcemia. We have to correct that. Serial monitoring of lactate has to be done to look for response to fluid therapy. Blood urea nitrogen creatinine liver enzymes to look for multi-organ dysfunction. CBC as clinically necessary. So coming on to the so take home message for today's lecture would be, we have to recognize shock in initial compensated phase, and we should not wait for blood pressure to fall and land up the patient in decompensated phase and ultimately leading to irreversible stage of shock. Fluid therapy is the mainstay in early stage of shock, as well as in early stages of septic shock as well as hypovolemic shock. Careful monitoring is required to assess the adequacy of fluid therapy. And for warm shock, we have to start noradrenaline, and for cold shock, adrenaline is preferred vasoactive agent. These are my references: Surviving Sepsis Campaign and recommendation for hemodynamic monitoring, particularly in children. And thanks to all the contributors. Thank you, ma'am.
Yeah.
Yes, sir.
Thank you very much, Dr. Neeraj. Are there any questions? Actually, there are no questions. So I think there will be a 20 minutes lunch break. And then after that, we'll meet for the next two lectures post lunch. So we will meet at So now there is a break for 20 minutes and we will again meet at 2 p.m. A very good afternoon to all of you. So in the post-lunch session, I'm going to start talking about the multi-system inflammatory syndrome. And actually, I'm not able to share my screen as the previous speaker has stopped sharing the screen. So a very good afternoon to all of you. And I am Dr. Shalini Tripathi. And I will be talking today about the multi-system inflammatory syndrome in children. So the learning objectives for the today's session will be that what is this multi-system inflammatory syndrome, when we are going to suspect this particular syndrome, and what are the clinical features when we will suspect it, how the stepwise evaluation we will do for such patients, and what is the WHO diagnostic criteria, and what is the management, how we are going to manage these patients. So multi-system inflammatory syndrome is a new multi-system disorder that usually follows COVID infection by 2 to 4 weeks, and it mainly affects children and adolescents. And the first case which was reported, it came in the April 2020 after the COVID first outbreak happened. And the illness presented just like the Kawasaki-like illness. And very particular and very peculiar thing about this was that all these cases of multi-system inflammatory syndrome, they had a gap of around 1 month from the COVID peak in that particular area. So how common this condition is? So first, it is very important to note that it is not a very common condition. Less than 1% of all COVID-19 in children and adolescents will be having the MIS-C. And the proportion of hospitalized patients, if we see, around less than 10% of the children who are hospitalized with COVID-19, they can have multi-system inflammatory syndrome. So how this happens? So what is the pathogenesis of MIS-C? The pathogenesis of this condition is incompletely understood. It is diagnosed in the children who had previous COVID infection, which may be undetected or asymptomatic in the first time when it happened. And it can also happen in children who are having the antigen or the COVID PCR positive, that is with the active infection. And the possible mechanism of inflammation which is given, it is immune dysregulation or antibody mediated enhancement and T cell mediated damage. So it is very well explained in this picture, which is I have taken from Dr. Satyen Lakshman's beautiful pictures and diagrams. So as we see in this picture, there is stage 1. So what happens in stage 1? The child gets infection, and most of the time in children, this infection goes undetected. And then this virus, it colonizes in the pharynx, as shown here by the pink color. And then in the secondary phase, in the adults, what happens? There is a ARDS like picture, that is a pulmonary phase, which is usually skipped in children because they don't have the ACE2 receptors, which is the receptor of attachment for COVID virus. Then what happens? These viruses, these colonized viruses, they activate macrophages, which in turn activate helper T cells. These helper T cells in turn activate B cells, plasma cells, which produce a lot of COVID antibodies, and they produce all the set of inflammatory mediators, TNF, interleukins, and all of them together, they produce a kind of cytokine storm around 1 month after the infection occurred in that particular child. And these cytokines will antibodies that produce this hyperinflammatory state, which affects almost all the system from head to toe in a child, which can affect actually, and this is called as multi-system inflammatory syndrome in children, in short, MIS-C. So if we see from in this diagram from head to toe, the patient can have the meningeal irritation. Then in the lungs, it will cause pulmonary edema, consolidation, atelectasis. Because of that, child will have the hypoxia, desaturations. Then there will be mucosal inflammation. Because of that, the child will have the conjunctivitis, the cheilosis, and the angular stomatitis. In the heart, it causes very particular, very similar to the Kawasaki disease, coronary artery aneurysms, which lead to shock. And ventricular ejection fraction decreases. Because of that, the child has a very important and very dangerous complication. The child develops shock. Then it can also affect the kidney, and in the kidneys it will cause the acute kidney injury and ARF-like presentation. In the GIT, there will be pericholecystic edema, mesenteric adenitis, ileitis, colitis, and ascites also. In the skin, there are there is a rash present, and this rash actually, especially if we have some child in which there is conjunctivitis, rash, and the multi-system involvement, especially after 1 month of COVID peak in your state or in your city, then please think of this condition after rule out the common infections. So this point is very important. We will always diagnose this condition only after excluding the common infections like dengue, scrub typhus, etc. The pathogenesis one is also given in Nature's Review Immunology Journal, that as is shown in the left diagram, the children in which there is a very low viral load, they have a very good interferon response and they are able to clear virus rapidly and they don't develop this condition. They have a very mild disease or almost asymptomatic in the beginning. But on the right hand side, if you see the children who are having a very high viral load, the interferon response is not adequate, and that because of the virus persistent in that particular child for a prolonged period of time, then this actually hyperinflammatory, this red bar occurs, and the levels of the chemokines and the interleukin 6 is very high, and then this is a like immunity which is damaging the child's own body structure, autoimmunity type of thing, and that produces the multi-system inflammatory syndrome in that particular child. So I have already discussed that. So this diagram is also again from Dr. Satyan, and it shows that when we are going to suspect. So first and the foremost is the important thing that we should have at least fever of 3 days in that child, then only we will start thinking about it. Then myalgia, conjunctivitis, which is non-purulent, red VP eyes, then maculopapular rash, then lymphadenopathy, oral stomatitis, and there are extremity swelling with erythema, skin peeling just like the Kawasaki disease. In the head, in the headache, in the CNS system, the patient will have the headache, meningismus, and lethargy. In the cardiac, the patient will have the myocarditis, increased cardiac markers like TROP-T, pro-BNP, they will be raised, and coronary artery aneurysm. Because of that, the child will have the shock and hypotension, leads to hyperperfusion of various organs, especially kidney, leading to ARF and tachycardia. Then in the lungs, the patient will have pulmonary infiltrates and hypoxemia and chest pain. Then a very important clue, what you can get, usually patients come to us with a report of CBC. So in that CBC report, peculiar finding of MIS-C is thrombocytopenia and polymorphonuclear leukocytosis and lymphopenia. The absolute lymphocyte count, if you calculate, it will be less than 1000 per cc. In the because of the acute renal failure, the patient will also have the hyponatremia, and in the GI, the patient will have in the investigation SGOT-PT ratio increased, and there will be hypoalbuminemia. So in the investigation, very particular is thrombocytopenia, neutrophilia, lymphopenia, hyponatremia, increased SGOT-PT ratio, and decrease albumin. So in this clinical picture is there, especially after the peak of COVID, with all these, many of these markers, many of these investigation positive, putting everything together, you will make the diagnosis of MIS-C and not based on a single thing. So these are the mucocutaneous manifestations like conjunctivitis, swollen extremity, the angular stomatitis, red tongue, strawberry tongue, palmar erythema, and extremity swelling. And the rash is usually maculopapular and petechial, and it will never be vesicular. So in this season of dengue fever, it will be similar to dengue fever and scrub typhus. So there are reports of the MIS-C patients, which in the United States, they have divided these patients into 3 classes, which are the class 1, which comprise of around 35% of the patients, and they will be having a hyperinflammation, means increased inflammatory markers with more than 6 organ system involvement, and the most common organ system involved will be GI and cardiovascular system. These patients will be having COVID antibodies positive. They had actually COVID antibody positive, and they had mortality around 0.5%. The second subclass, which was seen in the MIS-C case series, the biggest case series of MIS-C published by United States. So this has also 30% of the patients, and they mainly presented, they're the worst and the most dangerous patients, presenting like ARDS and myocarditis. They were not antibody positive. Most of them, they were actually PCR positive, because most of the time we think that the patient will be having antibody positive. But in MIS-C, the patient can have the PCR positive as well, because there is a gray zone when the antibodies just start appearing and the inflammation is yet not subsided, in fact increasing. So mortality in these patients was highest in this series of in the terms of around 5%. Then the class 3 patients were the mildest ones, which were presenting like typical or atypical Kawasaki disease of increased age of around more than 5 years, and they were 65% cases were antibody positive, and 34% were antibody and both antigen positive, means PCR positive and antibody positive. But they very well they were very well treated by steroids or IVIG, and with the mortality of 0%. So this kind of spectrum they noticed, and we also think that if we are getting the MIS-C patients in our area, we are more likely to get the patients in these proportions. Now this slide explains that how we are going to differentiate MIS-C with severe COVID, especially if the patient is not having, sometimes you may not have the rash, you may just have the pulmonary, cardiac and GI manifestations. So in the paper published by Feldstein, they said that GI symptoms were more common in MIS-C as compared to severe COVID, in form of diarrhea, nausea, vomiting, and hypoalbuminemia, SGOT-PT, increased abdominal pain, etc. Mucocutaneous manifestations were more common in patients with MIS-C, that is 67% versus 10% in severe COVID. Then LV dysfunction and aneurysm, coronary artery aneurysm, were seen more commonly in MIS-C. But the respiratory symptoms without CVS involvement, that is, there is no coronary artery aneurysm, echo was absolutely normal, and only respiratory symptom, this is seen in patients of severe COVID, because severe COVID, if it happens, it mainly affects the lungs and produces the ARDS-like picture. In the investigation, the neutrophil and lymphocyte ratio was higher in patients with MIS-C as compared to severe COVID, and CRP levels were, of course, we are expecting also, because MIS-C, the whole pathogenesis lies because of the inflammation, cytokine storm. So the levels was much higher in the tone of around 152 as compared to 33 in patients of severe COVID. So all the things will be found in both. Most of the symptoms will be affected in both. Even the CRP will be raised in both, but CRP will be much higher in MIS-C, and in the MIS-C you will be finding more cardiac involvement, and in the severe COVID you will finding more pulmonary involvement. Then how we will differentiate MIS-C patient with Kawasaki disease? The clinical differentiation is that Kawasaki usually present above 5 years of age, but MIS-C can present to small infant to the adolescents. Kawasaki patients will have no GI or neurological manifestations. The MIS-C patients will have more prominent GI and neurological manifestations. Then sometimes MIS-C will happen without mucocutaneous manifestation, but for Kawasaki, the diagnostic criteria actually includes all the mucocutaneous manifestations, so they will be there in almost all the patients. Then MIS-C patient will present more, they will be more sick and they will present as shock. Kawasaki may not be like that. And the cardiac dysfunction in form of the arrhythmia and ventricular dysfunction will be more in MIS-C. If we see the investigation wise, then what will be there in MIS-C, we will be having thrombocytopenia, lower absolute lymphocyte count, and higher CRP levels in patient of MIS-C and not in Kawasaki disease. And very important, if we are suspecting MIS-C, even if the patient is not in shock, and it is must to do an echo to rule out the coronary aneurysms and to rule out the cardiac involvement. So now we are going to a very important part. Suppose we are having all those things and clinically the patient is fitting into this syndrome, then how we are going to investigate this child? So evaluation. So if we have a patient who is having an unremitting fever more than 38 degrees centigrades of around 3 days and more, and then there are multi-system involvement, that is clinical feature suggestive of MIS-C. And third, we have an epidemiological link to COVID, that is if the antibody positive or PCR is positive, or there is a history of COVID positivity in the family around 4 to 6 weeks back, then only we'll think about the syndrome. And then we will have to we will have to say that we are going to investigate this patient for MIS-C, and we will say that we have to see that patient is sick or the patient is stable. So if the patient is having shock and life-threatening manifestations, we will do a set of tests which will include both tier 1 and tier 2 tests, because the patient is so sick, we cannot wait for one step test and then to go ahead. Actually, we have to do all the tests together. And if the patient is not very sick, then we have to first of all evaluate for the alternative diagnosis, because if fever is there in these months of July, August, September, and dengue fever, typhoid, malaria, all these things we will first of all rule out. So we will always rule out these things because the patient is stable, so we have adequate time to do so. Suppose the patient is unstable, so we have to do tier 1 and 2. If the patient is stable, then we have to go for tier 1 test of MIS-C, and if it is positive, we will go for the tier 2. So stable patient, tier 1 followed by tier 2. Unstable patients, we have to do all the tests together if you have the if it is there in your hospital. So what are the tier 1 tests? It will comprise of complete blood count, then metabolic profile, which will include liver function test, renal function test, and ABG. And if ABG is not available, then only serum sodium, because we want to see the hyponatremia. Then for glucose levels and serum albumin. Then for inflammatory markers, to begin with, as tier 1 is CRP and ESR, and COVID antibody and PCR. So what is a tier first positive screen? So tier 1 is positive when we have CRP increased and ESR increased, that is more than 40 in first hour, and with any one of these 5, that is absolute lymphocyte count less than 1000, platelet count less than 1.5 lakhs, serum sodium less than 135 milliequivalents per liter, polymorphonuclear neutrophil leukocytosis, and albumin levels less than 3. So CRP ESR raised with any one of these 5, tier 1 is positive. We will go ahead doing tier 2 test. Tier 2 tests are mainly cardiac, inflammatory markers, and blood smear. In cardiac, you will do ECG and echocardiogram, pro-BNP, TROP-T levels for cardiac involvement. And for the inflammatory markers, we will do the procalcitonin levels, prothrombin time, and APTT, D-dimers, fibrinogen, LDH, triglyceride, and cytokine panel if it is available at your hospital, and blood smear we have to do. So what is a positive tier 2 screen? So in the ECG, in the echo, we will be looking for LV dysfunction, LV ejection fraction. If it is less than 35%, we say that it is a dysfunction. It was found in that series in around 20 to 55% of the cases. We will also ask the cardiologist actually to look for, particularly for the coronary artery size, and we will actually look for the Z scores, age specific Z scores, which are available online. Even the calculators are available to look whether there are dilatations or aneurysm or giant aneurysm is there in the coronary arteries. And these were found in that series in around 20% of the patients. So when we will call that coronary arteries dilated? So coronary artery Z score values, if it is more than 2.5, it is called to be that this is a aneurysm is present, and this has to be particularly age specific and sex specific. And if the Z score is more than 10 times, then it is called as giant aneurysm, in which we have to give the aspirin and blood thinners for a very prolonged period of time. Then we will be asking the cardiologist to look for the valvular dysfunction, pericardial effusion, and for the EKG, we are trying to look for the electrical conduction abnormalities. Pro-BNP in the pediatric age group, the cutoff is taken more than 400 picogram per milliliters, and TROP-T will also be done. Any one of them, if it is raised, it is indicative of myocardial dysfunction. Then inflammatory markers, we will do all these, in which the D-dimer levels, if the cutoffs are more than 2 milligram per liter, fibrinogen if more than 400 milligram per deciliter, they are called to be positive. In the peripheral smear, we will be looking for cystocytes and the Burr cells. Okay. And D-dimers, if the cutoff is more than 5 times of the normal, they are usually called that they are raised. Now I'm coming to the WHO criteria for the diagnosis of this MIS-C, which is having 6-point criteria. And for making the diagnosis, we should have actually all the 6 points fulfilled. So what are those points? So the age, the pediatric age group, 0 to 19 years. Fever of 3 days, 38 degrees centigrade is a prerequisite to make the diagnosis. Then multi-system involvement. What does this mean? That means these 5 points and 2 out of these 5 are present in this patient. First is mucocutaneous involvement, rash, conjunctivitis, and skin involvement. Second is hypotension or shock. Third is the myocardial dysfunction, pericarditis, valvulitis, coronary artery aneurysm, echo findings plus TROP-T or pro-BNP based increased findings. Then fourth is evidence of coagulopathy, increased PT, APTT, D-dimers. And fifth is acute GI problem. Patient is complaining of diarrhea, vomiting, and abdominal pain. So if any 2 of these 5 are present, we say that it is a multi-system involvement. Then there is a evidence of inflammation, ESR, CRP, or procalcitonin. They are increased. So if procalcitonin is not available, that's no problem. But ESR, CRP, both are increased. It is very, very diagnostic of this condition. Then fifth point is very important. When we know something, we always look for it and we try to diagnose that, make the diagnosis in that patient. But we should know that this condition is not very common. It was less than 1% of all the patients of COVID-19, of the children with COVID-19. So try to exclude if the patient is stable, just having fever, otherwise the patient is stable. Try to exclude typhus, dengue fever, malignancy, this macrophage activation syndrome, HLH, sepsis, toxic shock syndrome, viral infections, in which the dengue is most prevalent in this season. then only think about this particular condition, because all these things, all the markers, they will be positive in the other this green box conditions also. Then epidemiological link with COVID virus in terms of RT-PCR or antigen positive, or serology is positive, or the contact with the COVID positive patient is there. Even that is sufficient evidence to have a epidemiological link with the COVID virus. So we should have all the 6 points fulfilled to make the diagnosis of multi-system inflammatory syndrome in the children. So no single diagnostic lab test, no magical test which is going to diagnose. You have to think the whole picture as a whole, not one test. How we are going, suppose you are diagnosed, now everything is fulfilled and my child is fitting into this condition. How I am going to manage this? So the management has actually 3 parts. First, we know that it is a hyperinflammatory condition. So we have to give the immunomodulators as IVIG, IV immunoglobulin, corticosteroid, and sometimes you may need to give the biological agents like anakinra, which is an anti-interleukin agent. Then for the procoagulant state, because the blood is very, there's a propensity for the thrombosis, stroke. So the blood thinners like antiplatelet drugs, aspirin, anticoagulants, low molecular weight heparin, it needs to be given. And supportive care actually should be at the top. It will actually make the real difference in the management and the outcome of the patient. So this is a chart which is taken from Ministry of Health and Family Welfare of the patients who are hospitalized with MIS-C. So first, we will have to see that whether the patient is low or patient is stable. Is the patient is having shock, coronary involvement, cardiac dysfunction, multi-system involvement, life-threatening condition. If any one of these is present, then we have to treat this patient immediately. We will have to send the tier 1, tier 2 tests and start the management of as anti-inflammatory treatment, giving both the anti-inflammatory agents at the right time without any delay, because if we delay, then it will actually change the outcome of the patient. So methylprednisolone in a dose of 1 to 2 milligram per kg per day plus IVIG in a dose of 2 gram per kg over 1 to 2 days plus antimicrobials, because the patient is so sick and he is having fever. So the possibility of sepsis also we cannot rule out. So we can send culture, and which can be stopped after the culture is sterile. So we are also giving antimicrobials in the sick patient at this point of time. Then we will look at how the patient is behaving to this management. If the patient is improving, that's fine. But if there is no improvement or worsening of symptoms in around 48 to 72 hours, then we have to repeat IVIG plus methylprednisolone. But now methylprednisolone we will give in a higher dose of 10 to 30 milligram per kg per day. Usually 20 milligram per kg per day we give for around 3 to 5 days. And of course, this has to be supported by the other supportive management. It is also written in this algorithm that if the patient is unresponsive to this management, we may consider the anakinra, which is an anti-interleukin drug, which is the availability of which is very difficult. And but it can be tried if the patient is not responding. The dosage is 2 to 10 milligram per kg per dose, subcutaneously or IV, 6 to 12 hourly. Okay, suppose the patient was not very sick. He is fulfilling the WHO diagnostic criteria, but the patient was not having any shock. The saturation was fine. Then we have to rule out the infections first. And then we have to give the any one of the 2 anti-inflammatory therapy, either methylpred or IVIG. Methylpred 1 to 2 mg per kg per day and IVIG 2 gram per kg over 24 to 48 hours. Okay. Then the next box says that we have to give aspirin, but aspirin it's not to be given in each and every case of. MIS-C, and always look for the platelet counts. If the platelet count is less than 80,000 or the patient has some active bleed from any site, aspirin is contraindicated. Otherwise, for thrombocytosis and coronary artery aneurysm, if the size is more than 2 Z scores, coronary artery size is more than 2.5 Z score, then aspirin in a dose of 3 to 5 milligram per kg per day, maximum of 81 mg per day is given. If the patient is having coronary artery aneurysm, giant aneurysm, that is the Z score is more than 10, or there is a thrombosis, or the patient is having LV, left ventricular ejection fraction, less than 35%, that is the patient is having that LV dysfunction, then in any any of these three is present, then we have to start enoxaparin in a dose of 1 mg per kg BD twice daily subcutaneously. And when we are putting a patient on enoxaparin, we have to monitor with doing factor 10A levels, which have to be maintained between 0.5 to 1. Although this factor 10A levels are not very routinely available in all the labs. So now suppose the patient was in shock, we have given the treatment. Now for 3 to 5 days, steroid plus IVIG, and the patient improved. Then we are going to taper steroid, oral, we will shift the patient to oral steroid of prednisolone, 1 to 2 mg per kg per day, with the gradual tapering, patient wise, depending on the patient's condition over a 2 to 3 weeks, monitoring the inflammatory markers, and as the CRP and ESR they normalize, we will taper it off. For the patients who are having, which were in the shock and who had evidence of LV dysfunction or have some pericardial effusion, valvular involvement, or some aneurysm, so we have to do the echo, repeat echo to be done after 7 to 10, 14 days, then around 1 to 2 months, and then after 1 year if the initial echo was abnormal. And repeat ECG if first time there was some abnormality, then we are going to repeat ECG every 48 hourly till that abnormality resolves. So duration, actually I have discussed this, that immunomodulators, that is IVIG and steroids, we need to taper 2 to 3 weeks depending on our inflammatory markers, and serial cardiac monitoring to be done. Aspirin has to be given around 4 weeks after diagnosis till the platelet count and coronary artery normalize. And enoxaparin is given for 2 to weeks minimum after discharge, and we need to give higher enoxaparin if the giant aneurysm is there, and if the patient is having evidence of thrombosis, minimum 3 months of enoxaparin is to be given pending resolution of the thrombus. And enoxaparin also needs to be given longer if the patient has LV dysfunction which is continued. So for cardiac dysfunction at acute emergency, we have to give the supportive care to manage him, to give him hemodynamic stability, ensuring adequate systemic perfusion, serial echocardiographic assessment of the cardiac function, and the monitoring for BNP and TROP-T levels continuously we have to do. Not in all. If the first time the patient has normal values, we don't need to repeat it. We need to repeat only if the first time the echo and these markers were high, they were raised. So we need to really repeat it till we found that these things are normal. And patients with severe LV dysfunction are treated with IV diuretics, IV inotropes, dobutamine, such as milrinone, dopamine, dobutamine, to manage the acute LV dysfunction. So supportive care, as already discussed by the previous speakers, the management of the shock, management of respiratory failure, ventilation if needed, and management of multi-organ dysfunction has to be done. Antibiotic therapy is to be given if the patient has evidence of infection, sepsis, culture positivity, and gastroprotection. For that, we need to give the proton pump inhibitors. What is the outcome of these patients? Most of the time, the outcome of these patients was found in the trials, in the research papers, as favorable outcome with low mortality of around 1 to 2%, even though most of the patient children, they required intensive care and immunomodulatory therapies. But the effect of that intensive care and immunomodulatory therapy was good. The nature and the frequency of the long-term complication is, however, unknown because the post-discharge follow-up studies are still going on and we don't have the data at present. So what is the take-home message of this lecture? That multi-system inflammatory syndrome is not very common condition. We should know that it happens usually 1 month after the maximum peak cases, and we should know that what are the syndromic manifestations of this condition so that we can think about it. But always think of the common conditions first. Before just jumping to the diagnosis of MIS-C, think of the common conditions. Investigate judiciously if the high index of suspicion is for MIS-C is there. Provide good supportive care apart from IVIG and the steroid for the better outcomes. Ensure judicious use of medications, and the outcome is usually favorable. So my sincere thanks to all the contributors of this presentation. Suggested readings. Thank you. Okay, so this was my presentation. I'm going to stop my sharing my screen, and I invite Dr. Sandhya Chauhan, who is going to speak on the PICU management and the supportive care. Dr. Sandhya, please share your screen.
Thank you, Dr. Shalini. Okay. Okay. So a very good afternoon to Dr. Chandrakanta ma'am and all the participants here. Am I audible enough? Am I audible enough?
Yes.
Okay. So in this lecture, we are going to talk about a general care of a child in pediatric intensive care unit. So what are our learning goals? To learn the importance of supportive care in pediatric intensive care, and to learn the components of the general care of critically ill child and how to provide that holistic general care. Okay. I'm not able to change my slide. Okay. So once a child is admitted in pediatric intensive care unit, the main goal of admission in pediatric intensive care unit is early identification of the precipitating disorder, the assessment of the severity of the disorder with which the child has been admitted, and resuscitation of that critically sick child. So primarily the focus of attention is on the precipitating disorder while a child is admitted in PICU. But one thing about which we all must be aware and very conscious about is that intensive care setting in itself is a very hostile and dangerous environment. So on one hand, where our focus definitely should be managing the primary illness and the severity related to it, on the other hand, we should not forget the basics of the routine, supportive and preventive care in pediatric ICU. Now, this routine care is standard across the wide spectrum of presenting pathologies. That is, whether a patient is mechanically ventilated for a lung pathology, or is suffering from AKI, or is having a life-threatening MIS-C, the basic care bundle is same and has to be followed for each and every patient. Now, once we talk of this supportive care has three components. First is monitoring, second is prevention of nosocomial infections, and third is ongoing assessment and support. When we talk of monitoring, this is monitoring of the aspects of the patient related to the primary pathology per se. That is the physiological indices, whether the patient is responding to the treatment you have given, to evaluate the trends, to raise alarms. This has all been dealt with in previous lectures. Second component is the prevention of nosocomial infections. Now, there is a bundle of maneuvers which are practiced in intensive care unit to prevent this, and hand hygiene is the most important component of this bundle. This would be discussed in the second part of the lecture. Third is ongoing assessment and support. Now, apart from the basic disease pathology and monitoring its course, this deals with other aspects of patient care, which, if neglected, will not only make the treatment of the basic pathology difficult and complicated, but will also make the treatment costly, ICU stay longer, and even add substantially to the mortality of those critically sick patients. Now, these multiple aspects can be remembered very easily by the simple mnemonic FAST, HUGS, BITS. What you can do is, and while even listening to this lecture, what you can do is, you just prepare a checklist with the help of this mnemonic and use it every day on your daily rounds. Train your nurses and your ICU staff to use it and get it checked in every shift. This will help to keep a track of the key aspects of the general care of those critically sick patients. So let us see what are the components of this fast health spits. F is for feeding, A stands for analgesia, S is sedation, T is thromboembolic prophylaxis, H is head of bed elevation, U is stress ulcer prevention, G is glucose control, S is spontaneous breathing trial, B is bowel regime, I is indwelling catheter removal, and D is de-escalation of antibiotics. Out of all these components, spontaneous breathing trial has already been discussed in lectures on mechanical ventilation, and the rest we'll discuss here. So starting with feeding. Now, several RCTs have shown that early feeding, this reduces the incidence of morbidity and mortality in ICUs by improving wound healing, by decreasing the loss due to metabolic stress response, by improving GI function and integrity. Not only does it help in improving the nutritional status of the sick patient, it also reduces the complications and the length of stay. Okay, so how much calories should be given? Now, remember, in the acute phase of illness, this is not decided by recommended daily allowance or RDA, but it is decided by REE, that is the resting energy expenditure. And the energy intake that you provide should not exceed this REE. Now, there are certain formulas to calculate this, or if we just restrict ourselves to a target between 27 to 58 kilocalories per kg per day, this will provide the energy intake according to REE in critically ill patients. And your protein goal should not exceed 1.5 gram per kg per day. The caloric requirement increases if the patient over and above the primary pathology suffering with fever, or is a patient of burns, sepsis, is having sepsis, had trauma or activity. So you have to increase accordingly. Okay. Now, what are the modes of feeding? There are two, enteral and parenteral. Enteral, where the GI tract is directly used to deliver nutrients and calories either orally or through NG or OG tube, is superior to and is the preferred one as compared to parenteral feeding, where the nutrients are delivered into a vein. And this is for obvious reasons, because enteral feeding is more physiological, has a trophic effect on gut mucosa. It helps to prevent bacterial translocation, and thereby it decreases the incidence of sepsis. Is simple, cheap, easy to administer, and is associated with very few metabolic complications. Yes, it does have its disadvantages in the form of NG tube displacement or feed intolerance or risk of aspiration, but we resort to parenteral feeding only in conditions where enteral feeding is contraindicated, like in cases the patient is having GI bleed, or is having gut ischemia, or is a patient of intestinal perforation or obstruction. Only then we resort to parenteral feeding, because it has a lot of disadvantages, like it is non-physiological, is obviously expensive, requires venous access, and thereby increases the incidence of sepsis, requires very frequent monitoring for metabolic complications. Okay. So how do we go ahead with feeding our patient? So what do we do is, first you have to assess your patient for the presence of any contraindication for enteral feeding, like I just told, GI bleed or ischemia or perforation or obstruction. You have to evaluate your patient for this. Look for the presence of bowel sounds. If no contraindication present and your bowels and the patient's bowel sounds are present, you can start enteral feeds within 24 to 48 hours of admission, keeping in check to keep the head end of the patient elevated. Now, once we go ahead with this enteral feeding, again, there are two modalities. One is nasogastric feeding, other is post-pyloric feeding. You have to assess your patient for the risk factors for aspiration, like whether patient is having severe respiratory distress or recurrent vomiting, or has gastroesophageal reflux with history of aspiration, or is having delayed gastric emptying due to his pathology. If these risk factors are present, we will not go ahead with nasogastric feeding. It is the post-pyloric feeding that we'll have to resort to. But if these risk factors are not present, we can very well go ahead with nasogastric feeding. Now, nasogastric feeding is normally given in the form of bolus feed, where we start with 25% of the target volume on a 2 to 4 hourly basis. For example, we can easily understand like this. Suppose if there is a 10 kg weight child, and we have decided that in order to provide the required fulfill the caloric requirement of the patient, we have to give a volume of 500 ml. Now, what we'll do is, we'll start with 25% of this target volume of 500 ml. Now, this will be somewhere around 125 ml or 120 ml. Now, what do we have to do with this 120 ml? Now, this has to be divided into a volume which can be given for 2 to 4 hourly. Suppose if I decide that I have to give 4 hourly, okay, so there'll be 6 feeds. So once you divide 120 by 6, it will be 20 ml 4 hourly feeds would be given. We start with this. If the patient tolerates well 2 to 3 such feeds, we can plan for feed advancement at a rate of 25% of the start volume. What was the start volume? It was 20 ml. So a 25% increment would be somewhere around 5 ml. Okay. So if the 2-3 feeds were of 20 ml, the next volume can be 25. Then we can go ahead with 30, then 35 till we reach the target volume. Similarly, in post-pyloric feeding, we normally prefer continuous feeding. It is given continuous as a continuous feeding. Here, the start rate is 1 to 2 ml per kg per hour. Suppose the same child with 10 kg weight, so we'll be starting with 1 to 2 ml per kg. That is somewhere between 10 to 20 ml per hour. Maximum we can go with 25 ml per hour. Here also, we go on, if the patient goes on tolerating, we'll go on increasing the feed volume at a rate of 1 to 2 ml per kg at 2 to 8 hourly intervals till the target volume is achieved. And what is the target volume? In cases of children infants less than 1 year, it is 5 ml per kg early. In children more than 1 year, it is somewhere between 5 to 20 ml per kg per hour. Okay. One thing you have to take care that once you are planning for feed advancement, before you do that, pre-feed gastric residual volume has to be checked. That means, suppose you have given the feed at 10 a.m. At 12 or at 2 p.m., you are going to increase the next feed volume. What you will do, you will first try to aspirate for the presence of any residual volume in the stomach. This is the pre-feed gastric residual volume. If this volume is more than 150 ml in cases of higher quantity feeds, or is more than 5 ml per kg, or it is more than half of the previous feed volume. That is, if my previous feed was 20 ml and what I have aspirated at the end of 4 hours is suppose 10 ml or 15 ml, we'll have to hold the next feed. If required, prokinetics like metoclopramide or domperidone in a dose of 0.2 milligram per kg per dose can be given. Even if after giving medications the patient doesn't respond, we can resort to smaller volume frequent feeds. That is, if I am giving 20 ml 4 hourly, I can give 10 ml 2 hourly feeds or 5 ml hourly feeds. What should be the composition of the feeds? It should be such to meet the needs of the critically ill child, which in up to 6 months of infants, it would be breast milk or express breast milk or formula. In children between 1 to 10 years, milk-based feeds or others like dal and porridge also can be given. In order to increase the caloric density of these feeds, we can fortify them with the help of MCT oil or sugar or puffed rice. Okay. care has to be taken for supplementation of vitamins and minerals and recommended daily allowance, either IV or orally. You can even take the help of a dietitian to take care of the needs of children in PICU. Once the acute phase of illness is over, that is by 7th to 10th day of illness, we have to increase the calorie delivery to more than 50% from the present value in order to avoid underfeeding and thereby ensuing malnutrition. Okay. Next, we'll talk about sedation and analgesia. Now, critically ill patients, they often require complex medical procedures, frequent invasive testings in ICUs, thereby necessitating the provision of adequate analgesia and sedation in ICUs in order to decrease the pain and decrease the stress response. Always remember, these agents have to be used judiciously, intermittently, and with frequent monitoring of patients, because where under sedation will lead to stress with long-term consequences, over sedation will lead to the need for prolonged respiratory support and prolonged ICU stay, thereby increasing other complications. Analgesia and sedation, they are preferred over neuromuscular blockade because they are quickly reversible and allow for neurological monitoring. While selecting the agents for sedation, care has to be taken to use agents with minimal effect on the vital parameters, especially the blood pressure. Commonly used or preferred drugs are short-acting benzodiazepines like midazolam at a dose of 0.1 milligram per kg bolus, followed by infusion of 1 to 10 microgram per kg per minute. And for analgesia, fentanyl is the drug we use in a dose of 1 microgram per kg, followed by 1 to 5 microgram per kg per hour infusion. For pediatric ARDS, always remember these agents should be titrated for maximum desirable effect with minimal possible dose. This is very important. If sedatives are not completely effective, we can use neuromuscular blocking agents. The preferred one is vecuronium in a dose of 0.15 milligram per kg, followed by 15 to 25 microgram per kg per minute. In moderate to severe ARDS, neuromuscular blocking agents, they improve tolerance to mechanical ventilation by eliminating ventilator patient dyssynchrony. And they also help in optimizing oxygen delivery by facilitating gas exchange. But their use has its own limitations in the form of profound muscle weakness. So again, they should be used in minimal possible dose along with observing a daily neuromuscular blockade holiday for at least 1 hour in order to monitor patients for clinical movement and development of critical illness polyneuropathy. So always remember minimal possible dose and daily NMB holiday of at least 1 hour. Third is glucose control. In sick patients, especially in ICUs, blood glucose abnormality, especially hyperglycemia, is very common, it being a stress hormone response. And there are other factors also, like the pathology per se can lead to peripheral insulin resistance, or because of additional effects of medications being used in ICU, like steroids, we are using steroids, they can give rise to hyperglycemia, or fluids, if you are administering exogenous dextrose administration, again, that can lead to hyperglycemia. Both the duration of hyperglycemia and the index of variability of glucose levels, especially the peak glucose level, they are independently associated with mortality by increasing the need of inotropic agents or mechanical ventilation, also the risk of infection. Now, normally what happens that in all ICUs, they follow the protocol of testing blood glucose level at the time of admission. If normal, then continuing its monitoring at 12-hourly interval. Any abnormal reading is followed by more frequent monitoring at 2 to 4-hourly interval. The aim is to maintain blood glucose level below 150 milligram per deciliter. But again, you remember that aggressive attempts of lowering blood glucose level or keeping a tighter glucose level can lead to hypoglycemia, which is equally deleterious. So your aim should be a moderate glycemic control, which should be high enough to avoid hypoglycemia and low enough to avoid excess catabolism, ketoacidosis, or hyperosmolarity or risk of infection. Any blood glucose level of more than 180 milligram per deciliter, your first step should be reduce the glucose infusion rates that you're using. If patient doesn't respond, definitely we'll resort to insulin infusion. Next is pressure sores. They're common in PICU, incidence is 26%. Common sites are occipital region, nose, chin, neck, heel, sacrum, risk factors, everything that you're using in ICUs, mechanical ventilation, if the patient is a patient of hypotension, malnourished patient, having sensory loss, dependent edema, central line in the neck, so commonly used in ICUs. Length of stay is more than 96 hours, patient is predisposed to developing them. How can you prevent? Regularly examine the skin. Keep the patient, you have to train your nursing staff for this, and to keep changing the position of the patient every 2 to 4 hours a day. Provide adequate nutrition to the patient. Keep the sheets dry and wrinkle free. And alternately, you can use pressure mattresses shown in the photograph. Okay, this slide is showing you the classification of the pressure source. I'll just show you the photograph also, but first we'll go theoretically. In stage 1, it is intact skin. Skin is intact with non-blanchable redness. You'll just find a redness over there. Management is protective dressing, change in position. Stage 2, shallow open ulcer with red-pink wound. Here, after cleaning the wound with saline and water, use moist dressing. It can be a transparent film, it can be a hydrocolloid dressing, hydrogel, foam, alginate dressing, whatever is available with you. In stage 3 is a full thickness tissue loss with visible subcutaneous fat, and stage 4 is full thickness tissue loss with exposed muscle and bone, much deeper. In both these two conditions, if you just have to clean the wound, again, moisture absorbent dressing should be applied if there is no necrosis. There is an unstageable, also a full thickness tissue loss with base of ulcer covered with slough or eschar. Here, the necrotic tissue has to be first removed, perform debridement, and then you go ahead with cleaning the wound and applying moisture absorbent dressing. And the last variety is a suspected deep injury, where superficially you will just find a purple maroon localized area of discolored intact skin or blood-filled blister. You cannot, there be a lot of deeper injury present, which is not visible from above. Okay, so here this photograph is showing you non-blanchable erythema of intact skin. Here the skin is totally intact, but there is redness. Here there is partial thickness skin loss with exposed dermis, this yellow one. Here it is full thickness skin loss with subcutaneous fat visible. Here it is full thickness skin loss and tissue loss and bone visible. This is unstageable, where full thickness skin and tissue loss is there and a lot of necrosis is present. Okay. Next, we'll come to eye care. Now, the ocular surface is normally protected by the ability to produce tears, to blink, to close eyes with rest or sleep. All these mechanisms are compromised in intensive care population, increasing the risk of developing ocular surface disease. And we are ourselves, that is a part and parcel of the treatment. For example, if you are giving oxygen through an oxygen mask or through CPAP, the gas flows have drying effect on the corneal surface. If you're using sedation for the patient, it reduces the blink reflex. If you're using muscle relaxants, it decreases the ability to close eyes, leading to lack of thalamus. If your patient has already a neurological insult, it further reduces the protective mechanisms of the eyes, and therefore the cornea and conjunctiva, they are predisposed for conditions like exposure keratitis or corneal ulceration or infection. It is seen in quarter of patients. What can we do? Use lubricating ointments, artificial tears to keep the cornea and conjunctiva wet. How frequently? 1 drop every 6 hourly, both eyes. If eyes are not fully closed, you can use protective eye taping as is shown in the photograph here. It is very effective in preventing corneal erosion. In cases of infection, definitely antibiotic drops have to be used. Next is oral hygiene. Now, children in ICUs may not be able to maintain oral hygiene and normal saliva production, again because of part and parcel of the treatment. Like if you use sedation, if you use fluid restriction for the patient, if you have kept the patient nil orally, you're using drugs that may exacerbate xerostomia, all this can lead to difficulty to maintain oral hygiene and a reduction in the normal saliva production. This predisposes to oral colonization with drug-resistant organisms and plaque formation. They form a very important source of ventilator-associated pneumonia, and therefore regular cleaning of oral cavities, especially in the intubated kids, is very important. Antiseptic solutions like chlorhexidine can be used for this purpose. While cleaning, ensure that the dislodged plaques and secretions are not aspirated. For that, keep the head end of the patient elevated. Endotracheal tube cuff should be kept inflated. As far as possible, used closed suctioning so that this does not dislodge lower down. Okay. There are certain pediatric clinical guidelines. This is NHS GGC pediatric clinical guidelines, which are telling you how to maintain the oral hygiene of your patient. After for this purpose, this guideline has been divided into 3 age groups. First is for infants, neonates, and infants with less than 1 year no teeth, infant and children 1 to 3 years with teeth, and children more than 3 years with teeth. Okay, so initially what we are going to do, wash your hands, dry your hands, don disposable gloves, ensure that the head end of the patient is elevated to at least 30 degrees, assess mouth using a lot of assessment tools are available online, you can use any, and then you start the management. In neonates and infants less than 1 year with no teeth, the main aim is to keep the oral mucosa moistened. How do you do this? Wrap a swab moistened with sterile water or saline around your gloved finger. Wipe the gums and the mucosa with swab to moisten the mouth and then apply yellow soft paraffin to lips. This has to be done every 2 to 4 hourly. In infants and children between 1 to 3 years with teeth, this procedure of keeping the oral mucosa dry every 2 to 4 hourly has to be followed. Along with that, every 12 hourly, brushing of the teeth with soft, small-headed toothbrush and a smear of fluoride toothpaste, it has to be done. In children more than 3 years, again, you have to keep the oral mucosa dry every 2 to 4 hourly. You have to keep on brushing the teeth every 12 hourly. The third thing that you have to add here is 30 minutes after tooth brushing, you apply 1% chlorhexidine gluconate gel to a foam stick and wipe oral mucosa, teeth and gums. And do not rinse or moisten the mouth with water following this. Okay. Next is stress ulcer prophylaxis. Now, children in intensive care units suffering with hypovolemia or decreased cardiac output or a lot of pro-inflammatory cytokine release, they are normally predisposed to acute gastric ulcers, stress ulcers due to decreased mucosal blood flow or decreased GI motility. And this leads to upper GI bleeding if the risk factors like thrombocytopenia, coagulopathy, organ failure, mechanical ventilation and high pressures are being used. Patient is a case of shock or prolonged surgery, has undergone prolonged surgery or is on steroids. So all these are risk factors for upper GI bleeding if a child is predisposed for stress ulcer formation. But prophylactic agents are not routinely advised because literature suggests that they may increase the risk of nosocomial infections. Then how can you help? Be cautious, observe for the nasogastric aspirates, their volume, especially their color. At any indication of GI bleeding, immediately contact the pediatric pediatrician or the pediatric neurologist for immediate treatment.
Connecting back. She has just lost the video. She's connecting back.
Okay. Okay. So we were just discussing this thromboembolic prophylaxis. Okay. So I was just discussing the risk factors for thromboembolic prophylaxis, and the most common factor which is responsible for thromboembolism in pediatric intensive care is central venous catheter. Okay. Now, what you can do is strict monitoring of the clinical signs and symptoms of venous thromboembolism should be done, must be done in children. Since most pediatric venous thromboembolism, they are catheter related, they can be either located in the upper venous system, giving rise to swelling, pain, discoloration in upper extremity, or in the lower venous system, giving rise to abdominal, inguinal, or leg pain, swelling, bluish purple discoloration in the lower extremity. If suspected, Doppler venous ultrasound is the commonest modality to diagnose venous thromboembolism. Now, standard unfractionated heparin or low molecular weight heparin prophylaxis, they are not routinely advised. But since we are talking of severe COVID-19, and Ms. C, here we do have an indication of low molecular weight heparin in the form of enoxaparin if the patient has evidence of thrombosis, or the D-dimer values are more than 5 times upper limit of normal, or the patient is having giant aneurysm with absolute coronary diameter of more than 8 millimeter, or more than coronary aneurysm score is of more than 10 Z score, or the patient is having left ventricular ejection fraction of less than 30%. This drug is contraindicated if the patient is having marked thrombocytopenia, that is platelet count is less than 25,000 per microliter, hypofibrinogenemia, that is fibrinogen activity is less than 100 milligram per deciliter, patient is a case of end-stage renal disease or had recent major bleeding. Once started, the duration is at least 2 weeks after discharge from hospital, or a longer outpatient therapeutic enoxaparin can be used if the patient is having a coronary aneurysm with Z score of more than 10, or is having a documented thrombosis, even we are going to give for more than 3 months pending thrombus resolution, or if the patient is having ongoing moderate to severe LV dysfunction, we have to continue. What is the dose? In neonate, it is higher, 2 milligram per kg twice daily subcutaneously. In 1 month old, it is 1.5 milligram per kg twice daily subcutaneously. And in children between 2 months to 17 years, it is 1 milligram per kg twice daily subcutaneously. Remove the central venous line associated with VT as soon as possible. Ensure follow-up ultrasounds also to screen for extension of VT, and other maneuvers like early mobilization and physiotherapy, compression, use of compression devices like stockings can be used. The other drug which we can use for thromboembolic prophylaxis is aspirin. Again, the indication should be there, like thrombosis or coronary aneurysm score of more than 2.5 Z score. Dose is between 3 milligram per kg per day to 5 milligram per kg per day. Duration is until normalization of platelet count and confirmed normal coronary arteries at more than 4 weeks after diagnosis. The contraindication is you are not going to use this drug in cases of active bleeding, or there is significant bleeding risk, or the platelet count is less than 80,000 per microliter. Next, we'll talk about the care of lines. Now, once the patient is on ICU, we use a lot of lines like IV lines or central lines or chest tubes or PD catheters. These lines are very important source of nosocomial infections, and therefore they should be observed very carefully. So we'll take them one by one. First, IV cannula. It should be examined at least once per shift for phlebitis. Whenever you are giving bonus injections, observe the cannula site. When you are changing IV flow rates, observe the cannula site. When you are changing the solution containers, observe them. You have to train your staff for this. There are certain scales available for the objective assessment of the IV sites and intervention. This is the Visual Infusion Phlebitis Scale, VIP scale. What it is, having 6 scores. Score 0 is when the site appears healthy. There are no signs of phlebitis, you have to observe the cannula. In score 1, one of the following will be present, like slight pain is present or slight redness is present. These are the possible first signs of phlebitis. Observe. If in score 2, 2 of the following are evident, like pain is associated with swelling or swelling with erythema, pain with erythema, if any 2 of the following are evident, this is the early stage of phlebitis. Remove the cannula, change the site. In score 3, all the signs, pain, induration, erythema, they are present. This is the intermediate stage of phlebitis. Remove the cannula, change the site, and consider treatment in the form of elevate the limb elevation, use of anti-inflammatory analgesic like ibuprofen, make the patient wear compression stockings or bandages. In 4, all signs evident and extensive pain, induration, erythema, along with palpable venous cord. This is the advanced stage of phlebitis, or we can say it's the beginning of thrombophlebitis. Remove the cannula, change the site, elevate the limb, use an anti-inflammatory analgesic, give compression bandages to the patient, and you can also use thrombophore, which has benzyl nicotinate and heparin in it. It not only dissolves the clot present superficially near the skin, you just have to apply the ointment, and this helps to dissolve the clot which is present superficially near the skin. Also relieves the pain and inflammation by increasing the blood flow. In score 5, all are evident and extensive. Along with that, patient develops fever. This is the established phase of thrombophlebitis. Remove the cannula, change the site, the treatment that I've already told, and it is the indication to initiate antibiotics. Okay, then we have a central venous line. It should be monitored regularly for displacement, bleeding, patency, infection, or for hematoma formation at the site. Remove as soon as no longer needed, or there is fever with no obvious foci. In case of chest drains, assess periodically for movement of the fluid column, amount and nature of drainage, displacement, breath sounds, subcutaneous emphysema. For peritoneal dialysis catheter, monitor the patency of dialysis catheter and the flow rate regularly. Remove as early as possible after peritoneal dialysis, and do not forget to send the peritoneal dialysis fluid and catheter for culture. Next is chest physiotherapy. Now, critical illness in itself, followed by intubation, mechanical ventilation in ICU, supine position of the patient, etc., they lead to deleterious effect on the lungs due to decreased cough reflex, decreased mucociliary clearance, sequestration of secretions, decrease in lung compliance, etc. Here, chest physiotherapy plays an important role in restoring lung health by increasing the drainage of secretions, improving ventilation perfusion matching, decreasing the work of breathing, and increasing functional residual capacity. Prone position in ventilated children, this can be practiced. This increases oxygenation in early stages of ARDS by increasing functional residual capacity, increases in ventilation perfusion matching, enabling drainage of secretions, and improving lymphatic drainage. The indications are severe ARDS, children with severe COVID, non-intubated children, and its effectiveness is being still investigated in moderate cases. If you happen to practice this about airway proning, there are 6 positions as you can see here in the photograph. It begins by lying in prone position on a flat bed, followed by lying on the right side, then sitting up, then lying on the left side, then semi-proning, and then returning to the proning position. Each position is practiced on flat bed for at least 30 minutes to 2 hours. At the completion of these 6 stages, again the cycle can be repeated. So the key messages were: understand that holistic care is needed for a critically ill child. Very easy to remember. The aspects that you have to take care of is fast hospitals. Prepare a checklist. Train your nursing staff and your ICU staff to use it. Use it on your daily rounds. Train them to use them at the end or at the beginning, in fact, at the beginning of their every shift. Give minimal sedation to your patients. Extubate them as early as possible to improve the outcome. Understand that nutritional support is equally important for early recovery. Physiotherapy done not only helps us to prevent sores, but also to improve the lung health. Always follow the dictum, first to no harm. Okay, these are the suggested readings for this presentation and the skills that we have just understood. Okay, next. How to manage asepsis in pediatric intensive care unit. The learning goals of this would be to understand what is healthcare associated infections, what are the common HAIs, how to maintain strict asepsis in your ward and minimize common HAIs, to understand the importance of hand hygiene and prevention of VAP through the VAP bundle. Now, healthcare-associated infections, CDC defines them as any clinical infection, localized and systemic, that was not present on admission. They are a very major cause of mortality and morbidity in intensive care setting, with 1/3 of the critically patients that suffered with them. There are 3 types: bloodstream infections, ventilator-associated pneumonia, and catheter-associated UTI. The risk factors are children less than 1 year or prolonged stay in ICU. Severity of illness at admission, prolonged use of sedation in ICU, use of broad spectrum antibiotics right at the outset, pre-existing medical conditions, or use of invasive devices in intensive care unit. Can we reduce it? Yes, by following the 4-pronged standard precaution: use of personal protective equipment, safe injection practices, respiratory cuff etiquette, and most important, hand hygiene. Okay. Now, this slide is showing you the posters of hand wash and hand rub. So for hand wash, soap or any hand wash containing chlorhexidine and alcohol can be used. These posters are available online. You can just download them and display the poster in your hand wash area. Okay, the full protocol of hand wash takes around 40 to 60 seconds to perform, and that should be performed in that way. This is showing hand rub. It can be 0.5% chlorhexidine with 70% weight by volume ethanol. Can be used for this. Practice for 20 to 30 seconds. These are the steps. Now, this slide is showing you the 5 moments of hand hygiene which have been recognized by WHO. We normally wash our hands effectively before entering the pediatric intensive care unit, but this 5 moments suggests that you have to practice the protocol of washing your hands while visiting each and every bed. For example, you have visited a first bed. Before the patient contact, you have to do it. Before any aseptic task, like you are examining the patient, you have to do it. After body fluid exposure risk, suppose you are examining the ICD bag also, you have to do. After your patient contact is over, and then after contact with patient surroundings. These are the 5 moments where you have to practice hand hygiene, and this has to be followed for each and every bed in your intensive care unit. Then PPE, personal protective equipment, comprising of gowns, gloves, and masks. These are clothing or devices donned for safety or protection while performing hazardous patient activity in order to interrupt disease transmission. Everybody must know proper donning and doffing, and understand that doffing is much more contagious. Following respiratory etiquette and cough hygiene, cover one's mouth while coughing using your upper arm instead of hand. Dispose of tissues, follow hand hygiene practices after touching respiratory secretions. In safe injection practices, clean the area where you have to apply injection with alcohol swab, use single dose vials and simple use needles. We can also display posters and distribute it to the attendants about minimizing visits and other relevant care, like before entering, remove your slippers and shoes, ornaments, watch, wash your hands, rub your hands before touching anything, don't sit on the bed, don't touch anything in ICU. If parents are being allowed, they should be donned in proper PPE. Explain clearly that all these precautions are being taken in the best interest of their and other children in intensive care unit. This is again a very important component of management, that is proper disposal of biomedical waste in intensive care unit. Disinfection and sterilization of ICUs and instruments with proper records should be done. Time to time culture audit of admitted patients should be done. Send the culture from walls, ceilings, suction pipes, other areas during regular surveillance, and as far as possible, practice antibiotic stewardship, that is the rational use of antibiotics. How to prevent bloodstream infections by using central lines made of Teflon and polyurethane, using minimum number of ports, insertion under aseptic precautions with scrub up to elbow, use of universal precautions, drapes over the patient, skin antisepsis with 2% chlorhexidine or 10% povidone iodine, use sterile gauze or transparent semi-permeable dressing. Antiseptic ointment should not be used for insertion. IV fluid administration sets should be changed every 72 to 96 hours. Disposable pressure transducers which you're using for CVP or ABG monitoring should be changed every 72 to 96 hours. How will you prevent UTI? Place the catheter aseptically, should not be placed without any indication. Closed drainage system should be used. If contaminated, replace it immediately. Catheter should not be irrigated unless absolutely necessary. Proper hand hygiene and aseptic precautions must be used when handling the catheter. Junction between the catheter and the drainage system should be secured properly and should be removed as soon as possible. Ventilator associated pneumonia. Any new onset of pneumonia after 48 hours of mechanical ventilation, this is VAP. This is the second commonest cause of healthcare associated infection. Incidences 20 to 36% and is associated with high mortality, morbidity, prolonged ICU stay, excessive antibiotic usage leading to antibiotic resistance. Endotracheal intubation is the most important risk factor for this. It increases the risk factor of VAP by 6 to 20 folds. The etiologies are hospital-acquired pathogens, Acinetobacter species, Pseudomonas aeruginosa, Klebsiella species, E. coli, and methicillin-resistant Staph aureus. How can you prevent VAP? By two-pronged methods. First is general measures to prevent HAI, and second is specific measures to prevent this VAP, which is known as VAP bundle. And there are 6 components in this. So we will take one by one. The first is to prevent iatrogenic spread of infection. How do you do this? By adherence to good hand hygiene practices. Use of universal precautions. Use of appropriate isolation techniques based on infectious organism. Second is to prevent aspiration of gastric contents. For that, elevate the head of bed to 30 to 45 degrees. Monitor or drain the gastric contents and avoid gastric distension. Third is improve oral hygiene by oral rinsing or cleaning with chlorhexidine 0.12%, use of toothbrush and oral swabs in daily oral care. Fourth is decrease endotracheal tube risk factors by use of inline suction equipment where appropriate and available, suction of hypopharynx prior to endotracheal tube suctioning and repositioning, maintaining endotracheal tube cuff pressure, and avoiding unplanned extubation and reintubation. Fifth is to avoid contamination of respiratory equipment that you're using by dedicated oropharyngeal suction equipment, prevention of accumulation of respiratory circuit condensate, prevention of contamination of ventilator equipment, change of circuits when visibly soiled or malfunctioning. Only sterile fluid should be used in humidifiers and nebulization. Next is VAP decreasing the duration of mechanical ventilation by practicing neuromuscular blockade holidays, minimal sedation and daily assessment of readiness to extubate, appropriate levels of sedation. Appropriate levels of sedation should be maintained such that ideally the child is awake but comfortable. Over-sedation will lead to weaning failure. Continuous heavy sedation should be avoided as this depresses cuff reflex and spontaneous ventilation and predisposes to aspiration of oropharyngeal secretions. So the take-home message is to understand the importance of hand hygiene, to take the measures for prevention of common healthcare-associated infections, and to practice WAP wind-up. These are the suggested references. Thank you for your patient listening, and sincere thanks to all the contributors of this presentation. That was all.
Thank you, Dr. Sandhya.
Thank you, ma'am.
For excellent presentation. And I don't see any question in the chat box for you. So thank you.
Thank you.
So with this, we come to the end of this 4-day long training program. And I hope that everybody must have gained some knowledge from this program, and we will be able to manage our children better. So I congratulate all the speakers for the excellent presentation. I thank our DGME sir, Dr. N.C. Prajapati sir, who started this training program, and our HOD, Dr. Shaili Avasti ma'am, who is the main person in planning this training program. I also thanks to Dr. CEO, Mr. Neeraj, and the Mamta team for giving us the technical support for this training program. And thank you all the participants for active participation. And before we start the post-test program, I just want to say that this giving post-test is mandatory for all the participants to get your e-certificate. And Mr. Neeraj will brief you about post-test before we activate the link. So thank you, everyone.
Thank you, ma'am.
Thank you, Shalini.
I request you everyone to please just see the screen, because I am sharing the message, the prototype of message which is shared with you on WhatsApp. This was the message. You have received the link for 3 days to join on the training of Zoom link and also the YouTube link. At the last of the message, you can see there is written sharing the Google link for the post test for day 4, 15th of July. You have to click on the link which is shown in the blue color on your mobile. If it is not in the blue color, request you to please save the mobile number from which you are receiving this message. Basically, this was the number. And after you click on the link, if you have already clicked on this link, the page, you can see the page which is saying that the response is not accepting correctly currently. I'll be activating the link, and then I request you click on this link again freshly. Okay, because as if you reload the page, your name, your mobile number, and the participant ID, which is very important for submission of your post test, should be pre-filled. When you click on this link, I am activating the link. You get 20 minutes to submit the post test. Okay. The link is activated. Now I request you all to please click on the post test link, and your name, mobile number, participant ID, and email ID should be pre-filled. If it is not, you have to click on the link again. Thank you. And if you face any issue, you can send WhatsApp on the number from which you are receiving the messages. You can also write in the chat box here, but I request you to please message me on the WhatsApp so that I can give the response or assist you quickly. And request you to not make calls, as I have to support all of you. So please message me on WhatsApp. Thank you. The time is started. We have 20 minutes. It's 15:35. We'll close it at 15:55, 20 minutes approx. Thank you. Everyone is asking for participant ID. I just want to repeat it कि आपको उस लिंक पर दोबारा क्लिक करना है लिंक एक्टिवेट होने के बाद। लिंक हमने अभी एक्टिवेट की है, आपने पहले से उस पर क्लिक कर लिया, इसलिए आपका नाम, मोबाइल नंबर, सारी चीजें भरी हुई नहीं आ रही हैं, तो आपको उस लिंक पर दोबारा क्लिक करना है। तो आपका नाम, पार्टिसिपेंट आईडी सब भरा हुआ है। थैंक यू। For those who have submitted their post-test, they can disconnect from the meeting. The certificate will be shared with you in 7 days, and all the PPTs which were used in this training will be shared via a Google Drive link. You can access all the presentation from there. Is there anyone still facing any issue with the post test? They can message me on WhatsApp if I missed replying them.